Thank you everyone for joining us today. The meeting will be started in 40 minutes from now. The room is open for everyone to join in. You can feel free to leave your email account, email numbers, and your country of origin in the chat box. Again, thank you so much for joining in. Thank you, everyone, again for joining us today. You are all warmly welcome to the program. Kindly leave your email address at the end of the program to let us know about participation and for the possibility of the certification. And I'm pleased to announce that every attendee today will receive a free copy of our PDF of the upcoming book on scoliosis. One of our upcoming books is on scoliosis, and I'm pleased to announce that every attendee of today's webinar will be able to get a free copy of the PDF. Again, thank you so much for joining in today. We are starting in about half an hour from now. Please feel free to share the invitation with all your friends and colleagues.
क्या देखना है? हाँ, ठीक। और
Can you please mute your mics? Kindly mute your mics. Can you please mute your mic? Thank you. Thank you so much again. We are starting in about 20 minutes from now. Thank you so much, everyone, for joining us today for the Scoliosis Day webinar. We are really pleased to have you all here, and it's a matter of huge honor to have so many good people from all around the world joining us today. We are starting in about 18 minutes from now. We have got five speakers, the top of the scoliosis surgery, the top-notch spine surgeons. We have Professor Baron Lohner. He's from Mount Sinai Hospital. He's head of the Department of Orthopedic Surgery at the Mount Sinai Hospital with Stanford University. He's also the pioneer of the, I might have read the description. He is pioneer of the vertebral body tethering technique for scoliosis, and it's a very important technique. Most of us who are interested in spine surgery, all our the neurosurgeons who have special interest in spinal surgery, as well as orthopedic surgeons who are performing spinal surgeries, really know about these techniques. These two techniques have also been approved by the FDA. The other one includes the Epifix technique. We all know about these. These are very important, especially in the growing children. So we will be starting in about 17 minutes from now. The other speakers include Professor John Rahman. Obviously, all of us know about him. He will be talking about the sagittal panels. We have another speaker, Professor Hamid Reza Abbasi. He will be talking about the olive technique. He's quite expert of the olive technique. To add versatility, we have we have tried to touch up almost all the possible things that we can actually gather. So we also have lecture on spinal cord stimulation for scoliosis, which will be delivered by Professor Giorgio Battis. He's from University of Cologne, and I think most of us know about him quite well. He's quite active on social media as well. You might have heard his lectures before, listened to his lectures before, and have read many of his writing and papers. We also have a lecture on adolescent idiopathic scoliosis, which will be delivered by Professor Juan Josehara. He is the president of Spinal Column Committee of Paraguay. And we have all these wonderful speakers. We have tried our best to touch up all the possible topics of importance and interest related to scoliosis. And we all know that June is the month of scoliosis awareness. And so we try to organize a meeting for the interest of all those who are interested in spinal surgery and scoliosis surgery. I want to also tell you and announce that every attendee of today's webinar will be receiving free soft PDF copy of our upcoming book on scoliosis. We've got a book in writing in pipeline right now, and we are really pleased to send everyone a free PDF copy of that upcoming book. Everyone who is joining us today for the webinar, please feel free to share the event registration link with all your friends, and kindly leave your email address and also the country of your origin in the chat box. If you have any questions, kindly use the Q&A, and those questions will be conveyed to the speakers, or they might be able to take them directly from the Q&A. We do have a few speakers who might not be able to join us live, and they have sent their recordings. In that case, if you have questions related to their lectures, kindly email to me, and I will send them as an email. I'm just sharing you the official email account of our society, of our organization. I hope you are following our Facebook page, the World Congress of Neurosurgery for Medical Students and Medical Resident, the WCN MSMR. It is under WFNS Education and Training Committee. We are also holding a module for of our course that will be on meningioma. It is known as M for meningioma. I hope you are all following it, and you will be able to join it. It will be held next month on 16th of July, and I really wish to see you all for that event as well. Hello, Dr. Juan Jose.
Hi, Noor.
Hi, how are you doing today?
Fine, fine. Yeah. And you?
I'm doing good today. How are you doing? So glad to see you, and thank you so much for sending your amazing lecture.
Okay. Thank you. Thank you for your invitation. I have a one surgery now. Aneurysm.
Oh, amazing! Which one?
Yeah.
Which one? Which aneurysm are you operating? Because
Yeah.
you
In
you.
the anterior circulation, the ACOM.
Oh, okay, ACOM. Usually, you have so many challenging cases. So I'm a huge fan of all the cases that you share. So I was just thinking, what you are actually going to parade today. So it's amazing, and thank you so much for sparing some time from your busy schedule.
Yes. Thank you for you. Thank you for you and your coordination. I have. You have challenging the war in the world because the learn with Zoom with the other professionality is very qualified team.
Yeah, you're right. It sometimes get a little challenging, especially we have got so many people around, and I usually organize it on my own only. So this time, I think Professor Luis Borba was very busy today, so he was not able to join us as well. So thank you so much. It's a huge honor for me. Thank you so much for the very big compliment. It means a lot to me. Thank you, thanks a lot. But I think that it is because of people like you who are around, who make a best of the team, and I think it is possible. You all make it possible for us to have to arrange a meeting. I guess Professor Baron Lauren is here. Hello, Professor Baron. Lauren, thank you.
Hello, good to be with you.
Thank you so much, sir. It's a matter of huge honor and pleasure for us to have you here. Thank you so much for joining in.
It's my pleasure, and it's nice to see a nice audience in attendance, and I'm glad to be able to provide you this specific area that is maybe of interest to your fellow surgeons and trainees that I know are in the audience. So I look forward to presenting and to answering some questions, and hopefully it will meet everybody's expectations.
Of course, sir, we are all huge fan of yours, and I think scoliosis surgery is very important, especially the tethering technique that has been very well endorsed. And but unfortunately, many of us do not have a very great idea. Neurological surgery, especially people have got interest in spinal surgery, but they do not have much idea about this the scoliosis surgery. So it was a matter of huge honor to have you here, and I was really overwhelmed to know that you are joining us today. And I've been telling the attendees that you are basically one of the pioneers of this technique, the tethering technique that has changed a lot of. It's a huge new thing to be involved, especially for those growing children in which we are supposed to proceed with surgery. So it is something that is huge and that should be discussed. So thank you so much for joining in and sparing time from your very busy schedule.
My pleasure. My pleasure. You can let me know when it's appropriate for me to start, and I will happily share my screen.
So, I know you have got a busy schedule, so I think our attendees are joining in, and several of them are on YouTube right now. They are watching the live stream. So
Oh, good.
I thank you so much. So they are really excited, and actually these are all recorded. So later on, so many people I've noticed that in 24 hours, up to 1,000 people view them on YouTube because we are involving so many people from all around the world with different time zones. So I guess if I don't want to hold you up for long. I know you have a busy schedule, so you can just
Yes.
if you feel like sharing it now, please proceed with it. We will be really happy. Thank you so much
Great.
again.
My pleasure. It says share screen is disabled by the host, so I think you have to open it up for me.
Yes, sir. Sure, sir. I have promoted you as a co-host. Can you share the screen now?
Great. Yes, I can.
Thank you, sir.
There we go.
So there's a brief description, a brief introduction, sir. Professor Luna does not require any introduction. I know every one of us know about him, but to be a few words as a formal introduction is Professor Baron Lerner is the chief of minimally invasive scoliosis surgery at the Mount Sinai Hospital with Stanford University. He's the professor of orthopedic surgery at the Icahn School of Medicine and also one of the pioneers of the technique of the vertebral body tethering. So we are really honored to have him today as our esteemed speaker. Sir, the floor is all yours now. Thank you so much. Sir.
Well, great. Noor, thank you so much for reaching out, and it's my pleasure to be with you all from various parts of the world and certainly across the world. And, as we have all learned during this pandemic, we are a lot closer than we realize through electronic media. And, I think it's opened the world even more than it was before. So pleasure to be here. I'll talk to you about some of the basics of vertebral body tethering. For some of you, this may be a little esoteric, and for others, it would be quite informative and interesting, but I hope you all take away something from this, and this will begin a conversation, and also perhaps for some of you, a pursuit of approaches other than fusion for some of our patients. The adolescent patient with scoliosis, idiopathic scoliosis, is a healthy patient with motion segments that are healthy, aside from the fact that they're deformed. So these patients to date have had spinal fusion as their only option. So let's get into this now. I have my one relevant disclosure is that I'm one of the developers, and I'm a consultant for ZimVie, one of the developers of the tether implant that I use in my practice and is used. So the standard of care for, as I said a moment ago, for the otherwise healthy adolescent patient with healthy motion segments is arthrodesis, is fusion. And we can delay this fusion if we can temporize with a brace and bring the patient to adulthood. We can do this later, but in many cases with progressive curvature, it's impossible to delay. And for many patients, arthrodesis is a very durable and an optimal treatment approach that will give a good long-term outcome. But there are some patients for whom it may not be the best. And really that, I think the natural history of how these patients perform over time and how they fare in their lives is based on the lowest instrumented vertebra, the LIV. So, remember, we're treating in this patient population, we're treating young patients who have a lifetime ahead of them. And in some cases, 70 or 80 years ahead. So what we do will have an impact on their lives. And as I look at the adolescent idiopathic scoliosis, the AIS patient, we have some basic primary concerns, depending on how severe their curves are. So for the most severe, and this is really more for earlier onset than adolescent in general, but for some adolescents, we really want to preserve their pulmonary function, either by preventing severe deformity or correcting it. And this may have an impact on life expectancy. And however we pursue our approach, we want to do this in a manner in which we minimize complications. So what works best in your hands, whether you're in Karachi, Islamabad, Delhi, or wherever in the world you are, throughout the world, you have tools at your disposal and techniques that make sense for patients, but really want to do so in a way that minimizes complications. And what might work in my hands may not work in someone else's hands, and vice versa. So look ourselves in the mirror as surgeons, as doctors caring for human beings and trying to improve the quality of their lives. And how do we do so safely? And then, at the pinnacle, how do we preserve motion segments? Because I think really that's as we refine our techniques and approaches, that's what we'd like to do for as many patients as possible. And of course, along the way, these patients care most. Some of you may not treat these patients. You may be dealing with more trauma and spinal cord injury and degenerative conditions of the spine. But for those of us who treat adolescent spinal curvatures, we've been trying to stay away from the word deformity for the patient's sake, because they feel very self-conscious and insecure about their body shape. That's what they care about most, is improving their shape so they don't stand out and they don't have these big asymmetries. So where have we been? And many of you are younger surgeons, and I always find that studying the timeline and the history of spine surgery is very helpful, because my gosh, we have come a long way from over the last century, and really modern surgery is a little over 100 years of age now, with the first spinal fusions performed for paralytic scoliosis at the turn of the last century. Both Dr. Hibbs and Dr. Albee were in New York, and they performed the first fusions. And then we had Dr. Harrington, Professor Harrington, who placed the first, the Harrington rod, the first metallic implant for scoliosis. And this was very, very controversial. It was presented in Chicago in 1958 at the Orthopedic Academy meeting, the annual meeting. And there were murmurs in the audience. This work is an abomination, a leading surgeon had stated at that time. It was really considered a very revolutionary approach, really, at that time, and it was controversial. And the same with Professor Suk, Ul Suk from Seoul, Korea. he presented, and I was in the audience in 1998 in New York, pedicle screws in the pediatric spine and the thoracic spine in particular. And that was very, very controversial. Nowadays, that is performed very, very commonly, almost universally around the world. Some of you may use hooks and wires and cables and screws. But screws are used very commonly. And then we have growing rods for early onset scoliosis, including magnetically controlled growth rods, which is very expensive and may not be available everywhere and is not without its problems. But my point here is to show that there have been some changes that are just incremental, but others that have been really revolutionary, including vertebral body stapling and tether, and we'll get into some of that. And this is the early fusion of Hibbs and Albee, the two separate institutions in New York. And then here, the first case report by Dr. Lenke and his team. And he did the one case and that was it, but with a very good proof of concept, and it worked very well. So this is the pictorial of where we've been. On the left here is the Harrington rod, a single long rod with a hook going down and a hook in a cephalad orientation, and then segmental hook fixation. I did a lot of these early in my career. I performed a lot of these surgeries. And then we did hybrid constructs with screws and hooks at the top, actually this is all screws, but screws in a more of a hook pattern, not as many screws as we performed later here. Along the way, we performed a lot of anterior fusions. So these were shorter fusions for thoracic curves, and we did these thoracoscopically. I'll show a little bit on that later. And then segmental screws, and now very similar to what we were doing in the thoracoscopic fusions, now we're doing tether. So there's an analogy there and a parallel. So arthrodesis is not a physiological operation. We've been doing it for 100 years, performing these procedures. But I would argue that as we, think about fusion arthrodesis as a salvage operation for hip and knee pathology, perhaps we should get to a point where, at least in many cases, it's a salvage and it's not the primary approach. There's some presentations, many presentations that have no alternative but arthrodesis, but maybe we can move a little away from this. And here's what I was discussing earlier. Maybe we can delay, and many of our patients come to us with their families and they are skeletally mature. And so their curves, although they can be moderately severe, they may not have a lot of symptoms, and the families ask, can we delay? And what would that be like if we do surgery maybe later? And so we performed a study in which we looked at the adolescent database and then the adult database of the International Spine Study Group. And what we found is if we delayed surgery, what it would look like if we took into account the natural history of curve progression. So, 20, 30, 40 years down the line, we see that there is, a more severe curve, and these fusions tend to be longer, often involving the sacrum and fixation to the pelvis. The operations are much longer with more blood loss, and the major complication rates 5 times greater than for AIS. So 25% versus 5%. And reoperations almost 11% versus almost 4%. So that's one of the pieces of information that families can appreciate and can benefit from. And here's sorry, let me back up. Here is just a comparison. We did a matched analysis and took a thoracic curve here and one in 40 years later. So we assumed this would be what this curve might look like 40 years later. And the patient's correction is not too dissimilar, but levels fused much greater, blood loss much greater, 4 times greater, operative time longer, et cetera, et cetera. So we performed an analysis looking at our adolescent patients who had arthrodesis, had fusion, And based on the lowest instrumented vertebra, the LIV, we assessed disc degeneration. And so for patients fused to L4, 27% had disc degeneration that was significant. And I would just ask anybody who's not speaking at the moment just to please mute your audio, just so that we have as few disruptions. I thank you. And if you fuse to L3, the patient, and these are 10 years after surgery, these are patients in their 20s, there's a 10% rate of significant disc degeneration. Now, these are asymptomatic at this point, but down the line, over the years, these patients are going to be symptomatic in some cases, particularly with the longer fusion. So if we fuse to L4, there's a high rate of problems. And for that reason, that main reason, perhaps we can apply this thoracolumbar tether, a flexible correction with screws that come in through the side, through vertebral body, and then a flexible cord, polyethylene cord. And we can maintain at least some mobility, and perhaps long-term, there'll be less disc degeneration distal to the construct, as opposed to fusion. And although fusion works very well for thoracic curvatures, here is a double thoracic curve. This patient in her 20s, 12 years postoperatively, had a great deal of neck and low back pain. Now, would this have been better with a motion sparing vertebral body tethering procedure? I'm not sure she's a real good candidate for that, because she has a proximal thoracic curve and her left shoulder is elevated. So generally you cannot correct with a tether. You can only address the main curve here. We're not able to get up through a left-sided approach, get up this high on either side. So this patient may not be an ideal candidate, but would the neck and back pain have been less if this patient had a non-fusion? I don't know, but time will tell. And some of our patients, this is another surgeon's patient fused to L2, and this patient developed significant disc degeneration below that required extension of the fusion. Now, one could argue that the sagittal plane was not well aligned and that this patient was destined to have problems. And some of this is on a genetic basis. Some patients are more predisposed to disc degeneration than others, as you see in your practices and in the clinic. And here's the downside, or the attributes of fusion. It's permanent, which is also a positive, but it's non-reversible. Some patients say, I had a fusion years ago, and is it possible to undo the fusion and have a tether? And some of these patients will develop adjacent segment problems, and there can be some functional restriction of mobility, particularly those, and many of my patients are athletic and they engage in dance and gymnastics and swimming. And some of you may see these patients as well. So they really want to have their spinal mobility maintained as well as possible. Although from Michelle Mark's work, and I'm a co-author on this paper, we assessed flexibility below an arthrodesis. This is at 10 years. I think this is a 10-year data. We do have 10-year data for sure. And we looked at the flexion and lateral bend mobility below the instrumented fusion, and we found that it was largely maintained in patients. So what they do is they become hypermobile below the fusion. So they were still able to maintain this up to 10 years following surgery after fusion. The problem is there's hypermobility that occurs, and that results in the disc degeneration that we saw in our other study. And then this study shows longer fusions result in less likely return to sport. So if you have an LIV of L4, only 20% return to their sport. They're relatively small numbers in this study. And, L3 and L2, less than if you had just the thoracic spine fused, in which 100% returned. So the ultimate procedure, I would argue, is one that corrects the curve and the body shape image disturbance, preserves pulmonary function, preserves growth and stature, flexibility, has a low complication rate and high reliability and a speedy recovery. And, I don't think any procedure has that perfected, but maybe this, in this patient is my first tether procedure, in which we had a double curve for this patient. We approached it through the right side and then the left side. And in our neck of the woods, in our country, we kind of project the x-rays with the left side on the left of the screen. So you may do it differently, but please note that. So is this the ultimate procedure? Well, here is an early patient in my clinic. She's now 3 weeks post-operative. And at 3 weeks, generally, we don't let the patients do very much. They walk, but no bending, lifting, twisting. And here we just demonstrate that already at 3 weeks, she's able to do this despite, a double tether, two-sided tether. So the promise, or the potential, I should say, of vertebral body tethering is that it is motion sparing, and that data is being generated. There is definitely a shorter recovery that we found compared to fusion, less blood loss. I've done now 401 tether cases, and we've only had to transfuse one patient, and this was an off indication, was actually not a pediatric patient. So in our pediatric patients on indication, there's never been any blood transfusions in all of those cases. It's reversible. So fusion still remains an option if for some reason it doesn't work out. And perhaps time will tell, there'll be less adjacent segment disc degeneration. And, this may be analogous to our motion sparing procedures in orthopedics for those of you who are orthopedic surgeons. Can we take this curved spine, make it straighter, and preserve mobility at the same time and function over the long term? And here's the patient at 5 weeks following surgery. And she's an intensive care doctor's daughter, performing, playing tennis shortly after her procedure. Dr. Mianji has been collecting data on X-rays, lateral bend and flexion, and basically found at least partial preservation of motion in these patients. When you have the patient bend against the tether here, away from the tether, there's less motion, as would be expected, because within the segments, that is, if you look here, because there's a check rein, but if you bend in the direction of the tether, there's a pretty good maintenance of intersegmental mobility. And we're collecting more data through various centers. Dr. Mianji, Dr. Samdani both have data. Here's a paper out of Turkey, a study in which they looked at a small patient group and they assessed trunk endurance as well as mobility. And the VBT group showed both better trunk endurance in this case here, trunk endurance versus the fusion group in flexion and extension, and average range of motion as well. And this was statistically significant in flexion, extension, lateral bend, as well as rotation. And this is a collage of the patients that we see and who, the families that gravitate to this particular operation. So what are the factors to consider? And, we spend a lot of time with the families discussing options. And these options are based on the curve size, curve flexibility, location. Thoracolumbar curves may be most, I think, importantly addressed with a non-fusion approach. We may push the limits of skeletal maturity. I won't get into that today because that's a more nuanced discussion, but that's something that I've delved into, and that we have applied this technique to more mature patients from a growth standpoint, which is very controversial. And again, I don't think that's a topic for today, but whether they play sports and family philosophy. I want something for my daughter that is largely just a one and done, as we say. It's a reliable fusion. It's not going to fall apart for the vast majority of patients. And yes, 20, 30 years down the line, there may be some issues, but that's preferable. Or I really want to avoid a permanent fusion in my daughter at all costs if possible. I understand there may be issues down the line, but we prefer to maintain as natural a spine as possible. So those are the kind of conversations. But there are curves and patients who are not really amenable to VBT. They have large curves. The curves are rigid. They don't bend out enough. If they bend to more than 30 degrees, certainly more than 35 degrees, we don't really apply this technique, although in some patients, we have done disc releases where we incise the annulus to help get better correction and realign them, and that has been effective. That's another controversial area and certainly not standard and mainstream. So, but we, have pushed the envelope and we've learned a lot, and I think we've helped a lot of patients doing so. But again, the majority of patients have to have significant growth. So we look at a left hand x-ray and do a Sanders score. If they're more mature, Sanders 6 through 8, they're probably not the best candidate because they don't have the ability to have this growth modulation, which I'll discuss in a moment. And maybe some of the more mature patients can have remodeling of their vertebrae despite not having very much growth. But again, that's to be seen later, and that's more controversial. So this patient really has to have the standard arthrodesis procedure. We worked very hard to save segments, went to fuse to L3 instead of L4 in this patient to maintain as many motion segments as possible with a very good outcome. And I hope I don't offend anybody with some of the images of patients. We may be a little less conservative in our culture, so some of those pictures are very standard. Here we performed and we're in the process of writing up this manuscript. Our United States FDA and our Setting Scoliosis Straight Foundation, with Noel Larson and myself being the principal investigators, Peter Newton and Michelle Marks as well, and our group. We collaborated with the FDA and had nearly 350 patients and parents and combinations of patient parents complete a questionnaire, a survey, and which we looked at different attributes of what families consider: type of surgery, fusion versus non-fusion, confidence in the planned correction, appearance, motion, failure. Is this going to fail, or is it likely to not to be sturdy and remain, reoperation and recovery? And we took different levels within those attributes and basically we're trying to understand the family's preferences and the trade-offs they were willing to accept. Bottom line, it's a bit of a busy slide and confusing a little bit unless you sit with it. Bottom line is that the patients preferred improvement in their appearance, but also improvement in their correction, which is appearance, but also improvement in motion. Those two were important. And that's where really, so fusion is this orange line. So the preference for fusion is right here. That's the baseline condition. And then the blue is non-fusion. And so below the orange line is a negative preference, and above is a positive preference. So the non-fusion patients really preferred that maintaining of motion. And of course, there's the other side of this where the actual amount of correction sometimes can be less with the non-fusion. And the worse that correction is, the less the patients would favor, or the families would favor, a non-fusion option. So these are the competing concerns. We want correction of our body shape asymmetry, but on the other hand, the families want motion maintained. And so we have to try to marry these two, and that can vary for individual families. So what we're doing with this operation is we modulate growth. So we basically, and Randy Betts should be credited, as Jim Ogilvy as well, with some of the early work in which stapling of the intervertebral segment was performed to tether or to slow down growth on the convexity of the curves. There is a relative anterior overgrowth and coronal wedging of these spines in patients. And so we want to take advantage of that and tether the growth, especially on the elongated convexity. This comes from the seminal work of Ian Stokes and his lab and his group, beginning more than 20 years ago, in which 1996 was this paper. They applied external fixators to rat tails, and these were analogous to vertebrae. And when they loaded asymmetrically, they created asymmetric growth as a result of this asymmetric loading on the rat tail. And with that, there was wedging of vertebra, and a scoliosis was created. And over time, that became worse and worse. So it's a vicious cycle. And so here, this is over time showing, as the weeks go on, the curves are worse and worse and worse. And that sort of provided the basis for the next phase, in which, well, here, stapling. This was attempted in the 50s, and you can see here it didn't work very well. But then here's an experimental study in animals, John Braun and Wall here. All of this led to, I think, the current state of tethering. Because when we applied these staples, and these are improved staples that didn't pull out because they're nitinol, and when they are placed, they go in orthogonal to the spine. So the tines are perpendicular to the spine, and they go in, and then when they reach body temperature, so we cool these in an ice bath, and when they reach body temperature, they clamp down so that they don't pull out. And you can see for a very mild curve, 37-degree curve, you can see quite an excellent result. But we found in many patients for larger curves that they didn't hold up well, and they ended up in the end with a fusion. So the difference between stapling and vertebral body tethering is we cross the entire vertebral body with a screw, and then we have a stronger, more robust polyethylene cord. So there's more power involved in this, and we can tackle larger curves. And then Peter Newton went from the stapling work that was done, and he in an animal lab applied these unilateral tethers, and he applied a single tether, and then he also applied a double tether. And what you can see is he compared this to a control. He actually created scoliosis, which was greater when you use two cables or two tethers. And that also resulted in an increase in kyphosis in these animals. And here you can see that. So untethered, so you just place the screws, but no cable. Here's a single and here's a double, and the curves are greater. And he assessed the health of the discs within the tethered area, and the water content was unchanged from control, and proteoglycan synthesis was only slightly different, but if anything more. So there was greater proteoglycan synthesis, and there was some change in collagen type with really unknown effect of that. But basically the histology is these tethered discs are thinner, but basically their health is maintained, at least in the animal study early on. Now, Frank Schwab took this another step, and he created, in a porcine model, he created scoliosis. And then after creating the scoliosis, he applied a tether. And he showed, so the tether, this is a little confusing, but basically here's the curve that he created in the model. And then applying the tether over time resulted in a decrease of the scoliosis. And it also resulted in an increase, in a relative increase in the kyphosis. And also in derotation at the apex. So with anterior correction, you can see here's the scoliotic spine that was created in the porcine model. And there's 28 degrees, 15 degrees of rotation, 3, 9. And then these decrease over time just with applying the tether and allowing growth to take hold. And here schematically showing the improvement. Here's the scoliotic spine. And then, just after their scoliosis was maximum. And then here applying the tether. And over time, there's less and less wedging of the vertebra. And again, here's that first case performed by Dr. Lenke. He eventually returned the patient to the operating room and had to release or remove the tether because the patient was overcorrecting. So you place the cord. This is a young 8-year-old boy, and then over time with not the most severe curve. So the problem with this is that you have powerful asymmetric growth with more growth on the concavity, less on the convexity. And then in time, there's overcorrection, and that had to be removed. I asked Dr. Lenke if he has seen this patient who would be now more than 20 years post-operative, or close to 20 years post-operative, because this was reported 12 years ago, and the patient had been operated years before that. So he has not been able to track down the patient. So in our country, the FDA approved this device, the first and only so far tether implant. I won't go into the details of the regulatory, but it's indicated for skeletally immature patients with curves between 30 to 65 degrees. Now, we would never apply this in a 30-degree curve, or almost never, unless there's less growth remaining, because this is going to overcorrect. But we probably go from 40 to 70 or 75 even. And these patients should have failed bracing or were intolerant to bracing. And this is kind of what it looks like schematically. We have a polyethylene cord here, and here are titanium screws, which are hydroxyapatite coated. And then we tension within. So we place the screws, place the cord. We use this T-handle device, and then we use we call it a snake, and we tension between each segment, and then we can lock the set screw in within the tension segment in which we achieve correction, each segment by segment. And when I do a thoracic construct, I do it through a very small mini open procedure here at a port above. We use a scope here. So typically for T5 to T12, we'll do these two small portal here, a mini incision here, and this is about 4 centimeters, very small. And then if we do a thoracolumbar, we're doing a thoracoabdominal exposure, and it's also a relatively small incision, and we can get T11 to L4 through this. And this is, it won't take a lot of time on the technique, but basically we learned a lot from doing thoracoscopic fusions. I'll show a slide on that. But we deflate the lung. We do perform single lung ventilation. Here's the lung. Here are the rib heads, segmental vessels, discs, and the pleura. We're incising with this harmonic scalpel. This is a fan retractor. And we place these screws just anterior to the rib head, and we have to stay out of the canal. So we've got to use precise technique, and we get bicortical fixation. If we are too anterior, we've got the aorta here. And it's very easy to have a screw that's too long and up against or near the aorta. So we've got to be very sensitive to that. And then this is what it looks like intraoperatively. And this is from Randy Betts. He shared this slide with me, but basically here, patient with a wedged vertebra at the apex, and then 1 year later, this nice squaring off of the vertebra. And that's the proof of this growth modulation concept. I won't spend much time, but years ago, Peter Newton and myself as well in a separate study looked at the learning curve associated with thoracoscopic techniques. And it was about 27 or 28 cases in my series and 35 and 30 in Peter's series, so very similar. There is a learning curve to these approaches. And I think with our mini thoracotomy, where you can look in and use the scope, I think it decreases the learning curve. And years ago, when we published on thoracoscopic fusions, we were doing these procedures through just these small ports, and we didn't use a mini open, but I think that really helps. These were more, I think in some ways more difficult because we had to do a good fusion technique, and we used metal rods. Now we're using flexible cords, but it's a very elegant procedure. And this is the outline of the portals that we used many years ago. And so one would have surmised that I would have been one of the first surgeons to engage in vertebral body tethering, but I was really concerned. I had done 100 thoracoscopic fusions, and we published a lot on it. But I really thought the tether was going to fail. And some of you may say the same. This can't possibly work. The screws are going to pull out and the cord will fail and the corrections won't last. But I would say that, and we did a lot of anterior thoracolumbar fusions as well. And so we're now able to apply those techniques to tether. But really, we're seeing some very promising results. And I think there's some unpredictability of the tether that doesn't exist with fusion. So being able to predict who will do the best and when to intervene and what levels to intervene at and place screws and tension and how much tension to apply. Some of those things need to be learned still. And there will be some machine learning that will guide us. But here's an example. Here's a patient with a nearly 70-degree curve, 10-year-old girl. We lost 100 cc's and performed this T5 through L1 tether. And first direct, she doesn't look very good, but this is very common. They lean to the side of the incision because it hurts them. They're sore. This is at 4 to 6 weeks after surgery. The families are all concerned. The lumbar curve looks large. There's a proximal curve above. That looks a little bit more than it might be. But then as you see them again, they straighten out very nicely. In this case, she overcorrected slightly, but has reached skeletal maturity, and this really hasn't changed. And I suspect that this level will break at some point, and this might as well, and then she'll be very straight. But this is a big difference from what we started with. And today we tension less, so we don't put as much tension in the lower 1 or 2 segments, so that we leave a little slack in this, so that they're less likely to overcorrect and land in the sweet spot. And the early published paper with two-year results was very small publication of only 11 patients, Amr and Randy Betts. And their curve went from 43 degrees in these patients to 22 at first direct, and then further growth modulation. And so a small series with a nice outcome. And Peter Newton as well showed an analysis of a number of patients out to as much as 4 years following surgery. There's improvement over time, and then there's a slight uptick after 2 years, and probably that's due to some tether breakages over time. However, and where this really gets a very bad name, and Peter publishes this very honestly, they had a very low clinical success rate. Only 59% ended up with curves less than 35 degrees. 4 tethers had to be removed for overcorrection, so 7 out of 17 patients had revisions. Overcorrection, 1 had to have a lumbar tether added because their secondary lumbar curve became large. 1 was replaced due to breakage, and 1 revised to spinal fusion. But he represents the early work and the early clinical applications of this. And Peter presented then a comparison to spinal fusion. 23 VBT versus 26 posterior fusion patients, so a relatively small group, and we have a larger group coming up soon, where we use the data from the harm study group, part of the Setting Scoliosis Straight Foundation, and we're basically going to compare many more VBT to fusion patients. I don't think it's yet published, but we will be publishing, I believe, soon. And that's a larger group of patients. But bottom line is, in Peter's publications, and this given tether a bad name, there is a residual deformity of 33 degrees for the tether and 16 degrees for the fusion, so better corrections. 52% of the tether patients had broken tethers, of which 4 required revision. There was a 39% revision rate for tether, 13% overcorrected. So not the best results really compared to fusion for sure. Very low or no revisions for the fusion patients. And but in Peter's tether patients, almost 80% had open triradiate cartilage and 91% risk or zero. So what this indicates is that these patients are very young, very skeletally immature, a lot of growth remaining, and probably those patients are more unpredictable. And so, here is the comparison of tether versus fusion. In his series, you can see more residual curve compared to fusion. Not sure these are, fair comparisons. They're not quite the same case. This is a Lanky 1C, this is a Lanky 1A, but this is their publication. And, some additional, this case, maybe they probably today would have tethered longer segment of the spine by tethering only a shorter portion of the curve. I don't think that, that didn't result in satisfactory correction. I think having tethered that more fully, that might have avoided this complication, which resulted in a very extensive fusion. So had this patient been fused early on, they would have ended up with a shorter fusion and more reliable outcome. Then Dan Horchmeyer, he presented another series of 2 to 5 year follow-up, 27 patients, but the majority of them had closed triradiate cartilage, and 52% were Risser 2 or more. So these are more mature patients. And now the Peter Newton's success rate of 59% is now 74%. And this is curve magnitude less than or equal to 30 as opposed to 35. So starting to see improvements. And I think it's because Dan was performing this procedure on slightly more mature patients. He had a similar tether breakage rate of 48%. And he had some one revision for overcorrection, but he had a 21% revision rate, including 2 patients to fusion. Although it's better than Peter's results, I think because of the indications being different, I think further refinement is still required. And here's, Dan's revision case. And, I think some residual curve is left behind here. And so some of this might have been predictable. I think going a little more distal on this patient may have made a difference. And so we've all learned from some of our mistakes, and we hope to avoid this kind of scenario in a lot of the patients. But this is certainly in the literature, and we have to respect that. Reoperation rates have varied depending on the series, from 4% to 41%. And I think the reasons are the tether loosens or breaks, or it overcorrects, and then conversion to fusion can be performed for adding on or poor correction or just curve progression, a replacement of broken tether, and adding of tether. So those are the kind of laundry list of why reoperations are performed. This again is my first patient. Sorry, let's take that back. And here she is at 3-year follow-up. You can see a broken tether here, but she's now she's now in November will be 7 years follow-up. And I saw her about 1.5 years ago. So we have longer follow-up, and this is probably broken here too. So she has 2 breakages, and but she's holding up beautifully with a beautiful outcome and avoidance of fusion. And here, sometimes we'll see an overcorrection over time, as you see here. And this patient did not require any treatment and reached skeletal maturity without further overcorrection. We have some, and these are my patients. I had 2 cases where the screws, we had poor fixation, was pulled back, and this never went any further. I offered the family a revision here, but they elected against it. Here, the patient's screw is placed intraoperatively, but it pulled back and it hasn't moved. And it's been like this for about 3 years. There's another one just like it, but a little less pronounced and also hasn't moved. Here's a patient that was 10 and a half years old when she presented to me with zero, and she has this double thoracic curve. And we discussed with the family performing a focal fusion of the proximal curve and tethering below, or just tethering to see how this would go over time. But we were concerned about that this curve would take off and be a problem and would require a later surgery. Well, sure enough, the pandemic hit, and sorry, this is, I don't know why this says 2.5 months post-op, but basically the patient over time progressed, and we lost her to follow up because of the pandemic. And so here what we did is we fused to T12, and then we extended the tether below. So we removed the existing tether and just simply extended it down, and she's doing quite nicely and playing sports in her secondary school. And here's a patient with a double curve, and we just tethered the lumbar curve. It broke over time, and this thoracic curve became more severe. The patient really wanted me to revise with tethers of both curves, but we felt that it was important to obtain a solid, reliable result above at least. And then we added a second row of screws so we'd have a double tether. So hopefully better longevity of that cord. And Ahmet Alanay out of Turkey, they assessed complications based on the Sanders score. So Sanders 2, patients with much more growth had higher rates of mechanical complications, 60%. So their cords broke, they had problems, versus much lower rates for Sanders 3 in their growth spurt and post-growth spurt. So the younger patients are the ones, I think this is really lends credibility to the notion that you've got to time this correctly. And if there's Sanders 2, there's an 80% rate of overcorrection compared to a much smaller rate for Sanders 3. But here you go. So here's a patient that I operated on. She's a big athlete, big swimmer, and she starts to overcorrect. So we got her very straight at the time of surgery, and that was predictable. It was maybe too small a curve to address, and she overcorrected. But fortunately, she broke her tether, and she'll probably break here at some time, and she'll end up with a very nice outcome. I saw her recently. She's about 18 years old, so she's 5 years out. And she hits her swimming times after this surgery. She continues to beat her times. So she's an excellent higher level swimmer. And we reported recently on tether breakage rates. Just to say at 2 years, there's a 27% breakage rate. And for double tethers where we placed a second cord, and this was predominantly in the lumbar spine, versus single, they were similar rates. There was no difference. But there were no differences in clinical success rates. So despite a broken cord, these tethers were, these patients were largely holding up. There was most of the breakages occurred in the lumbar, 75% were lumbar tethers. And here's a patient that presented to me from another surgeon, had lost correction. He's a dancer actually, and wanted to preserve flexibility. So we revised by placing a second row of screws and placing the cord. I think time will tell whether this operation, I don't know why that yellow line is there, but whether this operation, this double tether, will be better than fusion. But I think we'll follow these patients long term. And then we've done some double tethers where, as I showed in that case, where we've done both sides. And you can see that when we compare it to fusion, and we've submitted this for publication, basically there's equivalent, this is for major thoracic curves, there's actually, better correction for the postoperative at final follow-up for the major curve in the fusion group. So significantly better correction. as well as for the minor curve. So for thoracic, you're going to get better correction overall for the fusion patients. When we look at the thoracolumbar curve type, there are actually very similar corrections for both the major and the minor curve. I'm not going to get into the details of this chart, but basically what this shows is the sagittal plane is maintained despite placing anterior screws into the lumbar spine. They don't develop kyphosis. Their lordosis is maintained, and that's very important. And that's work that we can highlight in the future. I've already shown that. And here's just some more comparisons of, doing a tether of both curves bilaterally versus fusion. Fusion's nice and straight, very symmetrical, looks great, but this patient has flexibility. And so which one will fare better over time? Time will tell. There were some complications, 5 revision surgeries in the VBT and 2 revisions in the fusion patients. I just have a few more slides, and then we'll have about 10 minutes for discussion if you'd like. Here's a patient. She's a dancer, cheerleader, and large thoracic curve and moderately large lumbar curve. And we performed a hybrid. This thoracic curve is too big for tether, but we kind of have the best of both worlds here in that we can fuse the thoracic and tether below. And maybe this will provide a better long-term outcome than have to fuse to L4. And here's a hybrid again, a patient that presented to me from Malaysia. Fusion above. This is a double thoracic curve, so we fused and tethered below. And you can see, as I mentioned earlier, the maintenance of lumbar lordosis despite having the anterior instrumentation is quite nice. And another hybrid case. And here admittedly, we've pushed the envelope of maturity. So we recognize that we're not going to be able to get a good correction with a tether here. Patient has little room for growth modulation, not quite skeletally mature, but a Sanders 7, Risser 4 probably. And so, but in order to avoid fusion to L4, we push the envelope, and we'll have to follow these patients as to how durable this outcome is. I think there may be some remodeling that occurs over time. And I think having a thoracic fusion may, be somewhat protective of the lumbar spine below. So to finish up, I think the use of VBT and growth modulation, I think, has promise. We're going to have to refine our indications and understanding of who the best patients are to apply this technique, which I think can achieve the triple aim of correction, growth, and flexibility. And of course, though, we need to follow these patients over the long term to compare them to the standard fusion and to assess those outcomes long term, and to assess disc degeneration both within the construct and adjacent to, and compare that to the rates for fusion. And I think some of these alternative strategies, hybrid fusion, tether in the lumbar, are really very promising. And more mature patients may be amenable, especially as we develop stronger chords. But for now, I think you want to apply this to Sanders 3 and 4 patients, better not Sanders 2, except that they have much larger curves. And expect that there will be a learning curve and a higher reoperation rate, especially early on. So I'll leave you with that, and thank you.
Thank you so much, sir, for the very elaborate lecture. Thank you so much for sharing your amazing information, and everyone liked it. And I'm myself so much impressed, because I don't think we really needed something like this with a lot of information. Thank you so much, sir, for sparing your precious time. I know you have a very busy schedule. Sir, there is one question by
Yes.
Dr. Nitesh Naranbhai. He has said that once correction achieved, do you cut or remove the tether? What is the typical age range that you would advocate tethering, or do you determine suitability not on age, but based purely on degree of scoliosis and Sanders grade?
Thank you. Great questions. We really don't intend on removing the tether for most patients. It's a second operation. There is scarring in the chest cavity, so you have to be very technically careful to not violate the lung. We've got to take down pleural adhesions. Now they're not always there, and I fortunately haven't had to go back very often. So we don't go back routinely, but if there is overcorrection, that we have no choice but to do that. And you can just cut the cord and the segments that are being overcorrected as the patient reaches maturity, then there's less need to do that. And we're working on a cadaver study in which we will develop interventional radiology techniques for releasing the cord. So we don't have to do a formal open approach or thoracoscopic approach to the chest cavity. And we can do these releases both in the lumbar and thoracic spine, hopefully through just a percutaneous approach and not have to admit the patient even, except if there is a violation of an pneumothorax where we could admit the patient. In terms of the timing and the age, probably best to go by curve size and Sanders. Because you can have a 10-year-old who's mature and a 15-year-old who is immature. And I think larger curves in younger patients, Sanders 2 even, we can sometimes address. We really maximize the correction at the apex. We leave the ends a little more slack. And we tell the families that there's a high rate of reoperation likely, at least for overcorrection, where we may have to just release the cord, but there's going to be some unpredictability. And those patients who are at or just beyond peak height velocity, their maximum growth spurt, those I think have a lower rate of reoperation. And we just let them get to the finish line and then let time take over. And there'll be breakages. And I tell the patients there'll be breakages in all cases and maybe at all levels at some point. Life is long. So inshallah, as some of you would say. And so with that, with tether breakage, we haven't necessarily seen a major loss of correction. There is some loss segmentally, but many of the patients, because of this growth modulation, are holding up very nicely.
Thank you so much, sir. Again, thank you so much for the very elaborate answer. And I really wish to have the privilege of inviting you again at some of our webinars, sir. Thank you so much. This is really huge for us. And let me invite our second speaker, sir, Dr. Hamid Reza Abbasi. We are really honored to have you here, sir. He's a very famous minimally invasive spine surgeon, and currently he's based in Minnesota. He's got clinics at Burnsfield and Alexandria. Sir has a lot of experience in the olive technique. We are all quite aware of the olive, the oblique lateral lumbar intra-body fusion technique, and he's the only surgeon who is currently performing the MIS DTIF, that is a minimally invasive thoracic interbody fusion. Sir, we are really pleased and honored to have you here today with us, and he will obviously we'll be discussing all this technique for sir. Can
Good
you
morning.
good morning, sir. Thank you
Do you
so much
hear
for
me?
yes, sir, I can hear you, sir. Sir, thank you so much for coming today. It is a matter of huge honor and pleasure to have your kind presence here. And we are really excited to listen to your wonderful talk on the OLIF technique for this adult scoliosis, sir. It is obviously a very important technique we should all need to know, and we will be really pleased for you to share your wonderful experience with us.
Well, good morning, and thank you for having me. For my colleagues in the United States, good morning. For the rest of the present people who are here present, and maybe good afternoon. I'm Dr. Abbasi. I'm a chief medical officer of spine. I'm a clinician, and I'm a minimal invasive spine surgeon. My background, I'm a neurosurgeon. And today I'm going to talk about minimal invasive correction of the scoliosis. And obviously, what I want to know you to know is that you are going to hear a lot about the classical minimal invasive approach to adolescent and childhood scoliosis. This is not what I'm going to talk about today. Certainly, this is a science for itself, correcting adult and juvenile scoliosis. We have a lot of experience with that for the last 100 years, actually. As a matter of fact, spine surgery started with this kind of correction for adolescents and juvenile scoliosis. But comparing to that, I want to talk to you about something else. I'm talking about here an 85-year-old patient with multiple comorbidities and non-ambulatory deconditioning. As you know, when we quit walking, our heart, cardiovascular system deconditions. And this is a patient practically is in high-level pain, non-ambulatory, and that even changed the dynamic for the entire family, meaning the entire family, if the patient is lucky to have a family, change their life to help this patient with normal and daily tasks that need to be performed. And I want to tell you a story about this because this is an actual patient of mine where the whole family had to take time off work over years to just help their mother. This is a patient who says, I don't want to live like this. I cannot live like this. And the reality is that the few spine, a very well-versed and experienced spine surgeon told her with her comorbidity, with her age, she wouldn't make it through a spine surgery, that she would need to correct the situation. This is not a classical juvenile scoliosis, and we have to come to this acknowledgement that the tenet of the scoliosis correction for juvenile patient may not apply here. The goal here is make the patient ambulatory and relieve the pain. I think, at least for me, that's the goal. Now, I want to as well add to that that this is a public health issue because for every single juvenile scoliosis, I can tell you there are 50 to 100 of patients like this, elderly people who their curvature is not as big or threatening as like a 90-degree juvenile scoliosis, but these people practically miserably live the last few years of their life. About 1.5 million spine surgeries are performed in the United States in 2021. They don't include people like that the picture I'm showing you, because many of these patients rightfully are sent back and are told, no, they wouldn't make it through a scoliosis surgery or a spine surgery period. And they're just told rightfully, because we are good at weighing the risk versus benefit, they're rightfully told they have to live with it. Many of them, they don't live with it. The condition, they get a cardiovascular bypass and then die of consequences of not being ambulatory and deconditioning. And practically, it's really, as we say, it sucks to be old, but I'm telling you, it sucks to be old and be in pain all the time. Is there a way to help this patient? And it all comes back to, is there a way that we can reduce the risk versus benefit in favor of giving the patient an option? Because all those my colleagues who send this patient back, they're right. They're good surgeons. They know that risk versus benefit is not in favor of this patient. So this is what I want to talk about today. Certainly, you know, there are lots of tenets of the open surgery that, you know, how you should correct certain numbers, how to correct a certain deformity to give the patient, we have some indication, there are numbers that we know probably help the patient in the overall outcome later on. But do those numbers apply to an 85-year-old patient that average life expectancy is 5 years? And how do they really translate in this group of patients? I think the true answer to that is we don't know, because we haven't started even treating this patient in a MIS to see, is it the same animal? And intuitively, I can tell you, I feel that it is not. Correcting the scoliosis or deformity in an elderly patient is a different animal, even though it's just, we talk about the Cobb angle and torsion and so on. I think different, we have to just gather the knowledge to come to that. But I can tell you about my experience that instead of doing it, and I have done minimal invasive T10, T9 to S1 scoliosis correction. But I have come, at least in my practice, to the conclusion that we can give many of these people a limited surgery and remove more than 80 to 90% of their symptoms and make them ambulatory. And I'm going to tell you how we do that. Now, the idea is that making a 10-hour surgery, half a gallon of blood loss, and I have been in those surgeries, 2 surgeons working 10 hours on 1 patient, and we use cell saver, blood transfusion, platelets, and so on, patient in the ICU for a week or 2. Can we reduce that to a surgery like this one that is literally 1.5 hours, and our blood loss is 185 cc? I'm using that word, that 185, for a good reason, because the way we measure our blood loss, we don't have suction, we don't have BOVI, we don't have bipolar, and I'm going to show you what we do. And we gather the sponges, weigh them before and after, and can we do that? If we can do that, and I'm going to hopefully convince you that this in 2022 is a possibility, we can help a lot of patients that wouldn't be a candidate for open old-fashioned scoliosis correction. So let's talk a little about how we do this kind of surgery. And as you know, we have been since 1950s, and since 1980s, we are doing PLIF and TLIF. And even since 1970s, we go anterior approaches and as well lateral approaches since 2000 or late 1990s. And as well, I'm hoping that all of you are familiar with oblique lateral interbody fusion anterior to psoas, where practically you perform an ALIF in a lateral position, still retroperitoneal. Many of these are limited to certain levels. Like, you know, it's very hard to do L5S1, the XLIF, or it becomes exponentially more difficult to do higher lumbar approaches for anterior approaches. But I'm going today to talk to you about 2 techniques. One of them is oblique lateral posterior lumbar interbody fusion, and the other one is minimally invasive spine surgery with direct lateral interbody fusion. We have published the papers, the technical paper for OLIF in 2015 and 2018. We did a clinical study we published. And in 2017, we published our paper about direct lateral, where practically we perform XLIF in prone position. Meanwhile, we have over 1,500 patients and over 3,300 levels that we have performed. And we gather our data very, very meticulously. And I'm going to give you some data that are published, some data that are still in the process of being published. You're familiar, I'm hoping, that with the Cambin triangle that Dr. Cambin in 1970s and 80s practically described an anatomical approach to the disc that is void of vessels and nerves. He obviously used this approach for endoscopic approaches, and in the United States, I can just tell you, like electric car, we neglected that. This approach, this technique went to Southeast Asia. They really refined that. And just in the last 10, 15 years, it's coming slowly back to the United States. And we are using that mostly for the endoscopic approaches, but there are many, many techniques that we can use this transcamin approach as well for fusion, which we are doing. Based on lots of experience that we gained with the oblique lateral posterior lumbar interbody fusion, we as well created the method of doing this procedure anterior to the nerve root with the MIS-DLIF technique. As you see, the DLIF approach is distinct, and that enables us to practically, with combination of these 2 approaches, put the cage lateral, right, left, or anterior, posterior for correction of deformity. In the study that we published, this was just a pilot study. I'm not going to recite you the study itself. It is published. I will send you the links that you can read it. But practically, we were trying to see how can we do a completely minimal invasive scoliosis that correct mostly the clinical symptoms. And I think what we are trying to do here is a one single approach or a combination of approaches that all can be done minimally invasively, in this case, OLIF and MIS-DLIF, that we can apply from lower thoracic to the sacrum And in this case, I'm just going to tell you that we have been working for at least 11 years now on an MIS approach for entire lumbar spine that we started from L1 to L5, and now we can truly perform it in the early, anywhere from T7 to S1 with very refined technology that enable us practically perform the surgery, discectomy, prepare the end plate, and even put a cage in with a truly MIS approach. This is an 8mm tube, as you see here, that look like a T. This is a tube that we place in place, and it will show you a video that shows how this is done. An entire other instrument that you see here enable us to go through that 8mm tube and perform a discectomy, take the cartilage off, and then we put a K-wire, and then over the K-wire, we put a titanium cage for correct the scoliosis. Here, you don't see the titanium cage because this picture we produced when we were still using a P cage, but this, meanwhile, we have been using a titanium cage. The two approaches that I'm going to show you, OLIF and DLIF, practically, even though we use the same instrumentation, the same setting, the same positioning of the patient, they are very distinct. And one is, as you see in the OLIF, we are in the cambium triangle, and in the views, as you see in the AP view, we are just lateral to the border of the bone, and in the, in the lateral view, we are just posterior to the border of the bone, and in the AP view, as you see, we are within the confine of the vertebral body. With the MIS-DLIF, we are in the AP view lateral to the border of the bone, and in the lateral view, we are anterior. In our approach, we try to stay in the posterior half of the vertebral body, and I'm going to show you some other pictures. Here is how it looked like in the scoliosis in the on the skin before we start the surgery. And in the surgery, in this kind of surgery, practically what we do, we enter the disc with a dilator, and then we put a tube in, and this enables us literally to increase the distance between the vertebral bodies, and so the distance in the pedicular space. And for most of the cases, actually, that enables us to remove any compression of the foramen and lateral recess. Many of these patients, actually, as a vast majority of these patients, they literally wake up and they tell us, I have back pain, but my leg pain is gone. And we have a lot of clinical data regarding that after having done that with 1,500 cases. The end result looked like this, where you would think this is a TLIF, but it is not a TLIF procedure. And as you see here, with the combination of these two techniques and some other techniques, we are able to put the cage very deliberately in the location that we want. And considering that most of the fulcrum or weight transfer in the spine is in the middle of the vertebral body, actually it's a little further back, but putting the cage in around this fulcrum enable us to correct not only for Cobb angle in the coronal view, but as well in the sagittal view, we are able to correct to a significant amount what we call lordotic deformity or so-called sagittal deformity. This is just one example. In all these cases, or a vast majority of them, I come from the left, and as you see, the position of the cage on the right, middle, or left is not by random. And as you see here, you see the osteophytes, how they are separated. I come back to that, but we found out that we can correct up to 7 degrees per level, comparing preoperative CT versus postoperative CT. As you understand that, and I'm a clinician, I'm not an academician, so clinical improvement is what I'm looking for. But what I can tell you that, you know, the preoperative CT that we get for all our patients, when patient stands up, usually scoliosis is about 30% worse. Whereas we understand that when we instrument the patient, patient lays down with the instrumentation, whatever carb angle it is, theoretically stays the same when they stand up. So meaning that even though in our paper we could show we can correct 5 to 7 degree per level, in reality, probably we can correct somewhere between 8 and 10 degree per level. And the result is, again, it's about the clinical outcome. And since the time is limited, I'm going to just make sure that you guys have access. As a matter of fact, if you just go to NIH, Abalsi, OLIF, Scoliosis, you can just get the paper and read the paper. So I want to show you actually a few results that we got from that paper, but as well from our entire patient population. The astounding thing is that these people walk within hours after the surgery. As a matter of fact, 96% of our patients, I'm talking about the elderly 85-year-old person with comorbidity after 4 or 5 level fusion, they walk 96% of them within 24 hours after the surgery. I have done thousands of open surgeries. I have never seen people after my open surgery with this speed being able to ambulate. And that translates as well into faster discharge from the hospital because they can walk and so they can be discharged. The reality is here as well that that this patient as well continue keeping a huge edge in recovery even after discharge. And again, I will come back to that. Again, I don't want to go into details about the outcome and the paper, things that are mentioned in the paper, because I want to introduce you to just the technique and the things that are important with that.
Sir, sorry
Yes,
for interruption. Sorry, sir. Thank you so much for the amazing lecture, sir. You may take as much time as you like because we are all looking forward to listen to all the things you have to say and your amazing slides and everything, sir. So please go ahead with. If you feel that you need some extra time, then we will be really pleased to listen to you for a few more minutes, sir. So feel free and to take as much time as you require and to feel comfortable.
Oh, thank you very much. Thank you very much. Now, I'm going to show you probably one of the most indicator for the outcome in elderly. This is a study of almost 388,000 meta-analyses that they practically look into all surgeries. And they found out the time under anesthesia itself, first of all, independent from the age, is an independent indicator for the outcome. Practically, this is talk to any of your anesthesiologists next time you do a surgery and ask them the question, what are the different profile of the risk for a patient when the surgery is 1 hour versus 4 hours? They can tell you all very easily what the kind of huge difference it really makes, that just the time under anesthesia. There are good indicators, especially in elderly, which is defined 75 years and older. The steepness of this curve is actually skyrockets. It becomes really, really higher. In a way, the 3 hours seems to be a magic number, especially in elderly. The risks associated with any kind of surgery, if the surgery is more than 3 hours, is skyrockets in elderly. But even in the younger generation, this study, again, I will make sure that you get access, you see down the access, maybe you screenshot it, practically says that for every additional half an hour under anesthesia, we add 17% to the combined risk of the surgery. This has nothing to do with what kind of surgery, and this is an average. We know for prone surgeries where patients laying on the chest, that number is probably even higher. And I think for most of the patient, how we reduce the risks is making a 5, 6, 7 hour surgery, making a 1 hour or 1.5 hour surgery. And we know that the MIS is not about the skin incision. If you look at the picture on the right and the left, it's not about skin incision that makes this surgery more gentle to recovery process. It's about what happened under the skin. What do we do in a surgery like that? We cut, we cause bleeding, we cook the tissue. Once we stop the tissue, we progress and repeat the cycle until we get to where we want to do our surgeries. Imagine you bypass all of that. I have been told by one of our colleagues that if you put all those small incisions together in my MIS, comparing to the right, you have the same incision size, but that is deceiving because on the MIS side, we dilate the tissue, and literally once you take the tubes out, there is virtually no scarring. This is a patient of mine. In 2012, I did a 2-level TLIF. In 2014, I did an adjacent segment OLIF, transcambing OLIF. In 2015, patient had an accident, had a car accident, and I had to take the patient back. And this picture came from that surgery. As you see where I did the TLIF, we are dealing with scar tissue, almost avascular scar tissue. It's good for the surgery. You know, 6 months later, you go back there, it doesn't bleed. It's easy. Whereas where I did the OLIF, it's pristine, scarless tissue. And that sort of, for me, explains why this patient walk within hours after the surgery, why this patient are discharged within 1.6 is our average day hospital stay for big surgeries. The data regarding the discharge is being tracked in the United States, especially in Minnesota. And these are public information that you can look up online. Average spine stay in the hospital for all patients with spinal fusion in Minnesota is 4.2 to 4.6 days. Our average spine stay for the hospital, including all those severe scoliosis correction, is 1.6. But looking at this picture, that explains why people have more to recover from one surgery versus another. All the muscle that we don't have to cut, we know as well the vascularization of the bone is through surrounding muscle. In a traditional TLIF and PLIF, when you go to the lateral gutter, which is a transverse process, you're removing 75% of the vascularization of the bone. It makes sense that this patient have less vascularization to the surrounding tissue that's trying to heal, so the healing process is longer. As well, we are spine surgeon, you orthopedic colleague of us, you understand it better than we neurosurgeon, but imagine you would your elbow surgery and you don't reconnect the tendon. We don't tell that our patient, but we do not connect those muscles back. And these muscles after the surgery do what they are supposed to do, they contract, and there is no signal back coming that it's enough. They go to spasm. Practically, this process takes a long time for the patient to recover from. And it truly, they stop having this severe spasm, severe pain once the muscle, which is denervated, dies, and we have created the scar tissue. All of that can go away by muscle sparing techniques. Now, I'm just going to talk about the technique of my surgery. And this transcambing surgery has been done in many, many ways. But the technique that we have developed requires 2 C-arm. And I think when one of the first things I tell in the labs that I have with many of colleagues, we have almost monthly labs now, patient, surgeon come and train with us. One of the first things I tell them, what they are going to see that we do a 3-level fusion in 1 hour and 20 minutes, skin to skin, like 3 cages. I just did that yesterday. 3 cages, 8 screws, all of that in 1 hour and 20 minutes. It has not to do with my technical skills. It has to do with technology. In a way, I compare that to driving versus flying. Yes, you have to learn flying, but flying 5 times faster than driving is not really a pilot skill. It is a technology matter. So 2 C-arms, and just positioning of the C-arm, it took me 200 cases to figure out what the best way to position this 2 C-arm in the wall to give me enough space to maneuver around, especially with scoliosis. The setup has to be very deliberate to be able to maneuver these machines so you get a true AP and lateral. Sometimes, if you come to my room, you will see these machines are totally doing acrobatic to get a true AP and lateral for that segment I'm working. And that's all what it's about. In scoliosis surgery, you position the C-arm for a good AP and lateral just for the level you are working, and then you repeat that process. And it's all about instrumentation that enables you to repeat this process. Go inside of the disc, take the bad disc out, put a spacer, a cage, in a very deliberate position. And then the rest is the minimal invasive kind of posterolateral instrumentation and fusion. Instrumentation and fusion, because we achieve as well MIS, we grind the surface of the facet, we achieve posterolateral fusion additional to interbody fusion. This is a study actually we published about 4 years ago. These are about 380 patients in 1 year from the hospital, all the spinal fusion in that hospital. And in this study, we compared the outcome, and as an indicator for the outcome, we took time on the surgery because we looked at the data. All the morbidity, mortality, return to surgery, infection, time to discharge, and so on and so forth, they all correlated with the time under anesthesia. In this study, obviously, as makes sense, the blue line, the regular TLIF with higher BMI, you see that the time under anesthesia as an indicator for outcome is increasing. The MIS TLIF is the red line. What you need to know, only one surgeon did that, and that surgeon is a truly star MIS TLIF surgeon. He has probably done 2,500 of these surgeries. He's very efficient, but even in his hand, after BMI of 37, the time under anesthesia and the associated risk with surgery go higher. By the way, this study was done with the cooperation of the hospital. We do these surgeries in a process that we call value-based purchasing, meaning the hospital sees what value they get from a new system. So this was the official thing in cooperation with the hospital. What they found out is that our surgery, OLIF, not only we are shorter in the OR, meaning the hospital, for the hospital is finances are a big thing, obviously everywhere, but especially in the United States. They saw that all that 9 highly skilled people that have to be paid in the OR, they have to stay in my room less than an hour versus multiple hours for other surgeries. But even with higher BMI, that we can provide the same profile of risk in our room compared to other surgeries that are significantly more risky in higher BMI. The patient that I did my surgery 3-level in 1 hour and 82 minutes in University of Minnesota yesterday had a BMI of 54.5. My colleague, Dr. Kim, did another surgery on another patient in another hospital. That BMI of that patient was 58.4, meaning that we have a good record of showing that we can do this surgery safely in higher BMI. And we do the surgery these days now as well in very smaller, not high acuity hospitals, in rural hospital in Minnesota, and we have 10 years experience on that. So what I can tell you that we have made it that we can do this surgery safely by reducing the risk associated with this surgery. I really like to show you 2 videos. And these 2 videos, just going to show you the actual steps of the surgery, and I'm going to explain that we have like more than 1,000 YouTube videos. Many of them they show the exact steps of the surgery. Many of them I explain pre-op pictures, post-op pictures, the surgery itself. But as well, 2 months into this, I couldn't really believe that this patient truly I can't treat. When I started this about 11 years ago, it was for me difficult to understand that what I would call that then indirect decompression can alleviate their radiculopathy and the spinal stenosis or claudication symptoms. But 2 months into that, I noticed that this patient, they tell me they woke up and the leg pain is gone. I know if it was hard for me to believe that, for our community, it's going to be hard to believe. So in 2012, I started getting patient testimonial that literally at different stages, some right after the surgery, some 1 day later, some few weeks later, some months, and some years later, that they tell their story. And I think for me as a clinician, that's all what matters. I know there are some indicators like pelvic incident, lordosis angle, and so on. These are all indications for outcome. But for me as a clinician, when a patient comes and says, after being in pain for 5 years, and was turned back from 5 surgeons. And I do a 1.5 hour surgery, and he says he woke up and the leg pain was gone, and now he can do daily activity. That is all what matters for me. But let me show you some pictures from the technique itself. And I'm going to bring now my YouTube. And again, you can just YouTube this. If you just go to YouTube and put OLLIF, and you get 1,000 videos, many of them patient testimonials, many of them technical pictures that show you how this surgery are done. But before we do that, I want to show you first this picture that I call it impossible picture just because I can find it easier on YouTube. Obviously, it's not impossible because I did this surgery. But let me just show you this picture, this video, which is just, I think the important part of it is just few, 1 or 2 minutes of the procedure itself. And that visualize you the concept that we call now, we don't call it indirect decompression, we call it anatomical restoration and physiologic decompression. Here you see a large osteophyte with the scoliosis, and we are able to get into that space. And this is going to adjust back and forth to demonstrate my point. But as you see, we go with the, I will show you in another video for 1 or 2 minutes, the actual step of the surgery. But hello? Okay, and then I'm going to show you one more video here. And that one more video is going to show you the actual step of the surgery as they are performed. And then I answer some question maybe after that. So now let me just come here. This computer is not really exactly cooperating with me, but I'm going to put this video that shows the actual step. This is a long video, and I have some videos that they show entire surgery from the beginning to the end as well. And if you're interested, we have labs, we have. Today I decided actually to explain these pictures and the patient and the case instead of putting a music. I'm going to silence this, and then this is a regular case. This is a 4-level case that I did just about, I believe I did it about a year or so ago. And this is a typical pathology I deal with. Elderly, multi-level, and let's talk about the actual steps of the surgery. First of all, you have to get pictures of the patient and find the true lateral for the level you are working. If you're truly trying to get a good picture from all levels, you are going to fail. But here, as you see, I go literally move the machines in the AP and lateral view until I get the end plates of the level of interest visualized. And then as well, you see there are many tricks to that. You see the pedicle. Once we get this level, and you see, I spend a lot of time to actually visualize the end plates. Sometimes I think as well is important for you to understand that if the patient has a rotational deformity, you have to as well move the machine in a way that you get a true lateral for the level of interest. All the other levels are going to be practically not visualized properly. But again, you visualize one segment, you treat that, and you replicate that process. That is how it goes. So here you see the neuromonitoring probe. It's insulated all to the tip, and there is the sleeve going over it. And we approach this probe into this space in the cambium triangle, as you see here. This is, you see, I passed the lateral border of the spine, and here they're not synchronized. So the right and left are not synchronized. That way you don't see that. But once you are there, the sleeves go down. We stimulate at 3 milliamp. We double check on 4 milliamp. Once we have a neurophysiologically silent area, then at this point, we put a K-wire in. The probe comes out, K-wire goes in, the sleeves goes out, then a dilator goes in. The dilator practically opens up the space and give us a path from the skin to the inside of the disk base, and that enable us to practically use this series of tools. And truly magic of this surgery are those specialized tools that enable you to do discectomy, prepare the end plate, get rid of the cartilage over this tool. And I'm always asked the question, can you really do the discectomy? Can you really prepare the end plates? After having done it for 1,500 cases and 3,300 levels, I can tell you, whatever you can take out with your open technique, I can take out with this technique. It will not be a problem to get the disc out. And obviously there's a learning curve involved with that, but no different than the learning curve involved with your TLF. The only problem is that we in spine, at least in the United States, after we are done with our residency and fellowship, the way we learn new things, we go to a weekend course and come back and we perform it until we do our, gather our experience with that. This is different enough that that is not a good way of learning that. But the learning curve is no different. You have to know the anatomy, you have to know the approach, you have to know the instruments, and then you can do a perfect discectomy. Go, if you just look it up, I have a blog on Facebook, it's called Neurosurgery Case Review. I put lots of cases. It's amazing how much material you can take out with this technique, but you just have to know the instruments. So if there is a disc that needs to come out, if there's a cartilage that needs to come out, there's no question, we can take it out. So here you see that I'm just going to go through these pictures individually. Here's the tube is going in. Over the tube, as you see this material, once we have done our discectomy practically, the tube goes out, the K-wire goes in, and the cage is a cannulated cage that goes over the K-wire. There are lots of details into that, including that you cannot angle it. You have to keep the trajectory. And you have to get x-rays along the way to show which direction you're going. But the end result is a cage that practically is interbody. This is, in some cases, as you see, this cage is eccentric, and many of my colleagues are going to say, but the cage is not in the middle, and that's, and so on and so forth. I can't just tell you from lots of experience, it doesn't really matter. In my patient population, the eccentricity of the cage doesn't matter. In many cases, I put actually the cage on purpose, eccentric, to correct some of the scoliosis. I'm just going to proceed and explain, in a different level. Now I'm adjusting this. I put a Jamshidi in, I get bone marrow and so on, but I wanted to show you this process for the next level, and then I stop there. This is a 4-level fusion. As you see, I'm adjusting the x-rays. So now I see the L4-5 better. And here you see that now all of a sudden L4-5 becomes more visible. You see the end plates, you see the pedicle. And all you need to do, you need to understand the anatomy of the patient, study their pictures, and adjust the x-rays that you see the level best that you are going to work next. And again, here you see that I'm just going to let it run now in its entirety for next minute. You go with the so-called neuromonitoring probe, you go to the Cambion triangle, you stimulate, you put the K-wire. Over the K-wire, you dilate. After dilation, the tube goes in, the discectomy, the instrument go in, you do the discectomy, you put the biologic in, and then you put the cage in. And again, at this point, all it's done, you repeat the process for as many levels as you want. We have done T10 to S1, but these are our average times. For a 1-level fusion, 1 cage 4 screws, our average time, I just did one yesterday on a patient with high BMI, that was 42 minutes. Our average time for a 2-level is 1 hour and 5 minutes, skin to skin. For 3-level is 1.5 hours. For 4-level is about 1 hour and 40 minutes. Now, this patient have a different recovery profile. All my patients from this week are discharged within a day or two. Even I'm talking about the 4-level fusion that I did 3 days ago, and the patient was 78 years old. Now, by being able to reduce the risk, we are able to provide this to many, many more patients. And obviously, we have clinical results that support that we can specifically this elderly give them an option that probably they didn't have it available until now. Now, we have a lot of more information, but I'm going to just be respectful of everybody's time, and I'm going to stop here and answer questions if there is any. Thank you very much, and it has been a great pleasure for me to be able to present you my data.
Thank you so much, sir, for the amazing lecture. We are really honored and pleased to have your very kind presence. And thank you so much for the very elaborate points, especially regarding technique and everything, sir. It means a lot to us, and I think everyone enjoyed it so much. We have got so many viewers on YouTube right now. Like you have mentioned, I just keep, and many of my colleagues, they keep on following your wonderful cases on social media. We follow several of your videos, and also we have subscribed to your YouTube channel. It's very informative, especially for us young neurosurgeons who are especially interested in minimally invasive surgery. Sir, there is one question from Wael Al-Abbas. How to select the appropriately indicated patient? That's how you select it.
And it is, I think that is probably the most important question. You know, every surgery we do, every kind of new technology we have is a tool in our hand. And what is the proper indication for that tool? That is the question. Now, I can tell you that for me, it was a journey. When I started this, obviously, I had to gather my own experience, and I was very cautious. My indication in the first year or year and a half was only cases that I would have done an ALIF for, meaning that, you know, not much stenosis in the spinal canal, not much foraminal stenosis, but axial severe degenerative changes with mostly axial pain, and between L1 and L5. L5S1 has a different learning curve. Once I got good at this, I added L5S1. Then once I got even gathered more experience, I added grade 1 spondylolisthesis to that. Then after I have done about 400 cases, I added grade 2 spondylolisthesis and scoliosis up to 7 degree. And after 700 cases, I added scoliosis up to 15 degree. And I just can tell you, it has been a journey for me. Once you get better, you can expand on your indication. I'm going to tell you, after 1,500 cases, the cases that I do. I do anywhere from thoracic 7. This is the different technique. We published a paper about MIS DTIF. But I do anywhere from T7 to S1. I have the highest scoliosis I have done is 55 in the preoperative CT, not standing up scoliosis. I have done torsion, rotation of the vertebral body up to 40 degree. These are all become really exponentially more difficult. The cases that I won't do right now with this technique are still many of them. If truly there is an osteogenic spinal canal stenosis or facetogenic stenosis, and patient has mostly claudication and radiculopathy, in those cases, I do a laminotomy. I still don't do a laminectomy. I haven't done laminectomy or very few laminectomy in the last few years, but laminotomy where you go with a tube, unroof the lamina, you do bilateral foraminotomy with unilateral approach. And in those cases that they have osteogenic spinal canal or foraminal stenosis, I do a laminotomy, and many of those patients, that's all what they need. If after that they still have axial pain, and some do, then I come back. Now I have done a direct decompression. I come back and do a second stage OLIF procedure. So I think that the question of who is an adequate candidate for this is a matter of your experience, like any other tools. If you get better with that tools, you can expand the things that you can do with this tool. But definitely, this is just one tool. You have to, and I think all of us, if you're once we are experienced enough, when I was young and inexperienced, what I was doing was the only way of doing some procedure. Now that I'm more experienced, I know the way I'm doing the surgery is just one way, and the best surgery for a patient is the surgery that you are best at technically. Meaning, if you are best at ALIF, doesn't matter what data, what paper says. If you are best at ALIF, ALIF is the best way for you to help your patient. If you are best at TLIF, regular TLIF, so, and we understand that individual risk for a patient has a lot to do with what we are capable, comfortable doing. So, and I think the right answer to that long answer to your very, very legitimate question is that it has all to do with your level of experience.
Thank you so much, sir, for the amazing and elaborate answer. I think you have elaborated and explained several of the very important points in regard to the surgery, and it really means a lot for every one of us, those who are and especially interested in the minimally invasive spinal surgery. So there is another question from Sinan Al-Mullah. He's asking about the fusion in the MIS and scoliosis case, when to put screws by MIS and how we can do a good fusion.
Now, from lots of experience that I gathered, practically from different MIS technique, not only from this technique, like, from my XLIF, I used to use standalone or cage alone and so on. I had a higher failure rate. So in a hard way, after doing thousands of this kind of surgeries, I learned I instrument or fuse, posterolateral fuse my every single case. I can just tell you from another colleague of mine that did the adjacent segment, thought putting the cage alone is enough, and just 2 weeks later, the cage migrated. And I can tell you lots of my experience. So practically, I put pedicle screws in every single case, and I don't put them unilaterally. I put them bilaterally. Many of these cases, if they're adjacent segment, I do a mini Vilsti. I instrument everything MIS, and I do a mini Vilsti, and I've become a big believer in mini Vilsti, even though there's lots of finger dissection, you go through the muscle, it looks messy, but this patient do so well. And if patient had previous fusion, sometimes I go on the fusion adequate, let's say in the previous surgery, I go and cut the rod and do a mini Vilsti connect them, but I truly instrument and fuse every single of them. So if you're interested, we have a device that we call this facet decorticator. It's practically a tube that is eccentric. It goes, when you do MIS the instrumentation, you put a K-wire. This device goes over the K-wire, and practically what it does, it's because it's eccentric, it centers on the facet by orienting the device, and then we grind the surface of the facet and we pack it with biologic. So for 100% of my cases, I perform posterolateral, and everywhere I can, I try not to skip a level. I know in the open, in the juvenile kind of scoliosis, it is a usual thing, and there's nothing wrong with that, skipping even many levels with the screws. But my patient population, they are elderly, they have soft bones, they are not, and this is what I'm telling, these are not the same animal like a juvenile adolescent scoliosis. So I put in every level the biggest screw I can put, but with double C-arm, that becomes a really efficient kind of way of doing this surgery. And I put the biggest screws. 75% of the screws I put are 7.5 millimeter. And I put actually social media, think about that lots of people commented on that. No, pedicle is not like a stiff structure. It's malleable. I sometimes put 7.5 millimeter screws in 7 millimeter pedicles, because in a different diameter, the screw is elongated, and you can, with especially the screw that I use, have soft corners. It actually expands. You see, I have lots of, in my blog, I have lots of pictures. So I instrument every level. I put the biggest screws I can put in, and that's something I learned from my colleague, Dr. Kim, who's an orthopedic surgeon. They are much better than us neurosurgeon on bone work. Everywhere I can, I put the bicortical screws. As a neurosurgeon, I was scared of doing bicortical screw, going on the other side, close to the vena cava, close to aorta, and so on. But my colleague, who's an orthopedic surgeon, showed me, and I took my fear away. So these are some techniques that I try to do to make my construct significantly better. Even with that, the lower segment, especially S1, I get lots of screw loosening, and it becomes always in a situation like that a race between the fusion and hardware failure. Knock on the wood, in many of those cases, even though you see a little bit of a loosening, and these are 80-year-old patients, okay? These are not your young patient with good bone. Still, I can keep them asymptomatic until the fusion happens. So in this group, especially with the scoliosis, I have a 9.8% screw loosening, but only a very small fraction of them are clinically relevant, that if they have symptoms that I have to address, and like less than 3 to 5% of them, or half of that, what you radiographically see. So, but it's still it's a big deal. Now, so coming again to your question, I instrument every level with the biggest screws I can put in, with the bicortical. Many of my colleagues as well use metomethacrylate. They put it in the bone. I have done it a few times. I try to stay away from that because, as you know, metomethacrylate is a barrier for the fusion. It's plastic. Bone cannot grow through plastic. So that's the only thing I try to avoid.
Amazing, sir. Do you think that there is any role of the BMP in MIS screws? Sir, can it be good for
very much. BMP, bone polymorphogenic protein, we know it works. We know it is. I mean, I think that all the studies show that it is a very effective tool in the fusion. And I wish we were in a perfect world that I didn't have to be worried about that. But as you know, it's a very expensive material, okay? And I'm not part of the university, meaning that if the hospital look at my cost of doing surgery and all of a sudden they have to make a loss at multi-million-dollar in a year, they're going to, I mean, understandably, they're going to limit the delivery of the care. And so I'm being very conscious about that. And I use it in a special situation for the lower level, for their failures and so on. And that is unfortunately something we just have to deal with. That. Let me tell you a story. When I started this process, the first paper I published about the OLIF and MIS transcameron approach was not my clinical data. It was my economic data, because it is great if I could give every single of you a Mercedes, but truly our society doesn't have enough capacity to do that. But what is the area, that the Goldilocks of giving the care that we can afford? So my first paper in 2015 was an economic paper that we showed, contrary to lots of other technologies, that you bring something fantastic and it makes the cost of the delivery 5 times more. We can deliver this actually cheaper to the healthcare. Every minute in the OR is 64, it was in 2015 data. Every minute in the OR was $65 to $94, like in Mayo Clinic. Every minute in the OR is $140. In a smaller hospital where they don't have too much overhead, it's $64. Now you make a 7-hour surgery, a 1-hour surgery. The impact is huge. And we could show that we save, just by converting the fusion, if we would have converted the open to minimal invasive fusion, our impact would have been $3 billion annually. So that was my first patient. And that is the long answer to your question, do I use BMP? I believe in it. It's a good material. But if I, as a surgeon, in private practice, if I am not conscious about the cost of my delivery of my care, I'm going to bankrupt the hospital, and then no care will be provided.
Exactly. So thank you so much. Exactly. You're so right in that way. So there's another thing that is really recognized right now is the role of MRS in the neuromuscular type of scoliosis. So I don't think there is much literature about it right now, but so do you think that it could be helpful for the neuromuscular type of scoliosis, since they say that they advocate a lot for that way as well?
Well, I can just tell you, I'm not a classically juvenile pediatric trained scoliosis surgeon, and that this question should be answered by experts like my colleague, Dr. Kim, is a traditionally trained scoliosis surgeon for juvenile and so on. And I can just tell you the technique can be useful, like, the wrenches you use to fix your motorcycle, your bike, some of that you can use if you're fixing your car and so on. So the technique, the elements probably are transferable, but I think, I just know of a handful of people in the United States doing this kind of truly MIS technique for even adult degenerative scoliosis. And I know very, very few people who have tried that for a juvenile scoliosis. Whoever asked that, this is a good question, but that is probably you're somebody who's younger than me, because most of the people are younger than me. This is a question you have to answer. You get into that. You take what my generation did and see how much of that applies to other region, other things. Like I'm just going to tell you, I just presented you a tool. How that tool can be, and I know how I'm using this tool, but you have to take this tool and see what elements of that tool you can apply to your practice, to other areas. I think the future is very bright. I can just tell you a story from I had a conversation with my colleague who is an endoscopic general surgeon. They went through this process 30 years ago. 30 years ago, they started this endoscopy, the laparoscopy, and so on. And they just gathered their experience. They didn't just start doing everything, laparoscopic. They started somewhere and they have developed it to a point that nobody stays in the hospital for a cholecystectomy. Nobody. You go and get the surgery and go home. As a matter of fact, there is a study that says if we would go back to the way it used to be, meaning keeping 5 days people have the cholecystectomy in the hospital, we would break our entire medical system in the United States. Yet that is what we do for spine. We do this surgery, they stay a week in the hospital, and with the staggering number of the patients that are going out there that need this kind of care, we have to find new ways. I hope many of you are listening to this. You are going to be the people that take the baton, take the torch, and carry it further.
Thank you so much, sir. It's really nice of you, and thank you so much, sir. It is all because of the mentors like you who are actually sharing, and they're so much dedicated. And I think that my generation is basically blessed to have people like you who can actually guide us and to teach us accordingly. So it's a huge blessing, especially after the era of virtual education. We are all able to have access to the best surgeons around the globe, and we can just go on and log in, and we don't have to travel or do anything. So it's a huge privilege, and I think we owe a lot to you. We are indebted to mentors like you. So again, sir, thank you so much for your time, and thank you so much for all the answers, all the detailed answers you have given. And I really wish to have the privilege of inviting you again in one of our future webinars. So thank you so much again for coming.
Truly my pleasure. Thank you very much for inviting me.
Thank you so much, sir. Now we are pleased to have another lecture from Professor Yoner Aman. I think most of you are already quite. Can you please, Doctor? Can you please mute your mic kindly, Dr. Hale Gabriel? Can you please mute your mic? Thank you. Okay, I'm going to now play. Actually, Professor Oner Aman is right now in Ivory Coast. He's at the very moment residing another meeting. So we are pleased to have him sending his recorded lecture on sagittal balance and pelvic parameters as clinical implications for scoliosis. Professor Oner Aman is a professor of neurosurgery with special interest in spinal surgery. He's head of the department of the Memorial Hospital in Istanbul, and you might have already attended many of his lectures. I'm going to play his recorded lecture right now. Thank you so much for your patient listening.
진짜 next level.
About these parameters, it's scoring. So I'd like to start from this point. This is a tree in front of a hotel. If you look at this tree, the tree is adapted to get the pellets here. And this is the pizza tower. It stays somehow. This is a mosque from Turkey. If you look at the upper part, you may say that it's upper cervical part. If you look at the lower part, it's lower cervical spine. This is a mosque again from Turkey. They have put some wires to get the mosque in a balanced position. This is a tree from Karachi, Pakistan. They have added some instruments to keep the tree in a balanced position. But everything is not so easy in the patients. There is only one aim of the patient, to keep the head over pelvis. For that aim, the patient is using some compensatory mechanisms. First of all, there is an extension on the hips. Then, if it does not work, the patient bend the knees, flex the knees to keep a good horizontal gaze, like in this patient. And in some cases, the sagittal balance disappears because of the pain. The patient was walking very good 1 week ago, but now the patient tries to keep an adaptation due to the pain, and the patient has lost the sagittal balance. I got this photograph from a pet shop. There is a trauma on the eye, and the patient has lost the corneal balance here. I will talk about the patient in the following of my presentation. So I'd like to tell you a tale. This tale is about an elephant, and it's from Mevlana Jalaluddin Rumi. The tale is the elephant in the dark. They have put an elephant in the dark, and they have sent the people inside. They told them there is an animal in the dark. Try to guess what kind of an animal is inside. And some of them touch the leg, some of them touch the tail, some of them touch the nose, and they describe the animal differently. But elephant, if you look totally to the elephant, if they could see all the elephant, they will say that it's an elephant. But if you look only some part of the elephant, you will describe different things. So some of our patients sent us some x-rays, and they asked me what kind of surgeries we have to do. If you just look at the lumbar area, it means you're just touching the leg of the elephant. But if we see at least the end of S1, we may see more parts of the elephant. Because if we see the S1, we may say that the patient is using the compensatory mechanism or not. Look, if you see the S1, and if it's in this position, you may say that the patient is not using the compensatory mechanism. If you see the S1 is coming parallel to the floor, like this, in these cases, you may say that the patient is using the compensatory mechanism, the retroversion of the pelvis here. This is a normal position of a pelvis, and you may see the hole in the frontal, in the corneal plane here. But if you cannot see the hole here in the pelvis here, it means the patient is using the retroversion of the pelvis here. So on the AP view, if the patient is using the compensatory mechanisms, it's getting the retroversion of the pelvis. And on the lateral view, the patient's trying to keep all the spine back, to keep the head over the pelvis. So if you see the S1 on the X-rays, you may say that the patient's pelvic tilt has increased, just looking on the S1 end plate here. So look at this one. It's parallel to the floor. We may say that the pelvic tilt has increased. If you look on the AP, again, we cannot see the hole, so it means the patient is using the retroversion of the pelvis, normal pelvis. So at least if I can see the head of the femur here, I can measure the pelvic incidence. Pelvic incidence is important because it's the fingerprint of the patient. It doesn't change in time. So pelvic incidence is important because you can measure it with kinds of softwares. I'm using the surgery map here. Pelvic incidence is important. Let's say basically, if I have calculated pelvic incidence, I know the patient will need, let's say, 14 degrees lumbar lordosis here. If you look at the mid picture here, the pelvic incidence is 33 degrees. The patient will need 30 degrees lumbar lordosis. And for that patient, 45 degrees lumbar lordosis will be enough. At the beginning of our education, we were asking our colleagues, how much lumbar lordosis will that patient will need? They will say that 40, 50. So we were having only one size jacket, and we were trying to put every patient in one size. But imagine that you're in a shoe shop, you need lots of different size of shoes. But at that time, we were not knowing about pelvic incidence. We were having one size shoe. So if I know the pelvic incidence, I know that the proper lumbar lordosis of that patient. So without making any measurements here, just looking on the x-rays, if I can see the cervical spine, I will see whole of the elephant here. So if I look just on the x-ray, I may say that the patient has lost the sagittal balance, the SPA is increased. The patient is using the compensatory mechanisms with bending the knee, with retroverting the pelvis, and also the patient has decreased the thoracic kyphosis here. If you make the measurements here, you will see that the patient's pelvic tilt has increased, and also thoracic kyphosis has decreased. So if you look at this fish example here, because of the loss of one of the eye, the patient cannot balance the coronal plane. So if you look on a patient here, the patient has a cervical scoliosis. All patients need to hold both of eyes parallel to the floor to get a good coronal balance and have no difficulty during the walk. Because of the cervical scoliosis, if you look on the x-rays here on the lateral bending films, we may say that the patient has a compensatory thoracic scoliosis to compensate, get the coronal balance here. So it means if you just correct the cervical scoliosis, the thoracic scoliosis will disappear after the surgery. So we have done just a cervical scoliosis here, and we have corrected the cervical spine. Now the eyes are parallel to the floor, and if you look on the x-rays, the patient's thoracic scoliosis has disappeared after the surgery. So for adult degenerative scoliosis cases, there are lots of measurements here, but the main important thing here is to learn the philosophy of the sagittal and also the coronal balance here. So we're knowing about all these parameters now. We need them to make a good plan before the surgery. This is a case example. This lady was 72 years old and had previous surgeries and bended forward in time. So the patient's walking was like that. So we need a good plan before the surgery. Now we're applying different type of osteotomies, and we have to decide it according to the softwares. Now we're trying an pedicle substruction osteotomy at L4. It didn't work. We added a conti osteotomy, we added an extra conti osteotomy, but it was not enough to correct the spine. Then we changed the type of the osteotomy. We applied a type 4 osteotomy, a corner osteotomy at L4 level. We added conti and an extra conti osteotomy, and we have seen that it worked for that patient. Then We measured the length of the rod according to the patient. So according to age, 39 degrees lumbar lordosis will be enough according to the pelvic incidence here. So the pelvic incidence was 56 degree, and the lumbar lordosis will need 39 degrees lumbar lordosis will be found for that patient. So we have bended the rod according to that patient. So we have prepared the rods. These were the rods before the surgery. It helps us to get an idea if we get a good lumbar lordosis during the surgery or not. These are the images during the surgery. We have also calculating the lumbar lordosis during the surgery. So we applied the pedicle L4 corner osteotomy. We get the X-ray during the surgery with dividing it on the upper and lower lumbar area here, and we combined it during the surgery. So the lumbar lordosis, 33 degrees lumbar lordosis, where we have achieved that. And this was after the surgery. So the patient has a good sagittal balance after the surgery, before and after the surgery, the clinical photographs here. So this was after the surgery. Another case, the patient has also previous surgeries. And if you look here, the patient is using the pelvic tilt, but could not achieve a good sagittal balance here. So we again used pre-bending rods here. And these are the images during the surgery. We also use a T-rod to control the coronal plane if we achieve a good coronal balance or not. So this is after the surgery, X-rays and chemical photographs. And we are also using kickstand rod technique during the surgery. So this was the first surgery. Then we revised it because we could not maintain the coronal balance. The kickstand rod technique is that you put an extra rod to iliac pin here, and you put an extra rod, you use a domino, and you use a strong rod holder, and you just extract it. So this is the technique I'll be applying. This is the cranial part. This is the cranial part. This is the caudal part. So put an extra rod, an extra screws on that side. Then while doing the surgery, this technique, you're correcting the spine on the coronal plane, but you're putting that patient in front on the lateral view. You lose the sagittal balance. But if you use a tie rod, we have applied a kickstand on the left side. The patient bent forward. And if you use a tie rod technique on the other side, it means you put an extra screw and rope, then you compress that part and you bring that spine to the back. So these are the techniques that we are using during the surgery, especially in the adult degenerative scoliosis cases. These are the case examples during the surgery. So this strengthens your system, and you can achieve a good coronal balance after the surgery. And this is another case example. The patient, we couldn't get a proper scoliosis graph while the patient is standing, and we have made the necessary measurements while the patient is sitting. So these were the parameters before the surgery. We have applied an L1 and L3 pedicle substruction osteotomies, and we could achieve a good sagittal balance after the surgery. So these were before the surgery and after the surgery. Open the patient's eye. The patient could not sit forward while the patient is sitting, but after the surgery, the patient has a good horizontal gaze. So the things that I would see as a keynote, we need a scoliosis graph to see all the spine and the head, and also the head of the femur to see all the sagittal plane and also the whole body. We have to decide according to the cause and result. In some cases, if you just solve the pain because of a lumbar disc herniation, you can achieve a good sagittal balance after the surgery. And you have to keep the age according to your planning before the surgery, because these kind of surgeries have a high complication rates and very high revision rates. Thank you so much for your attention.
Thanks so much, Professor Ulujaman, who wasn't able to make it in person. So he sent his recording because he's right now in Ivory Coast planning one of his own conferences. We are so much pleased. So he's not here live. And we thank you so much for all of you for attending this. I'm now going to push recording of Professor Juan Jose Hara. You might have seen him in the start of our lecture. He has got a case today on aneurysm, so he wasn't also able to attend it in person. It was so nice of him to send the recording, so I'm going to share his recording right now. If you've got any questions, kindly send them on the email address I have shared before. I'm going to share it again. And I will send your questions to all the speakers who have sent their recordings. Professor Juan Jose Hora is the president of the Spinal Column Committee of Spinal Column Society of Paraguay. And we are really pleased to have him. He's a very nice person.
From Paraguay, South America, and my topic about today is adolescent with scoliosis. The definition of the three-dimensional
I think the
deformity without
can you let me know, are you able to listen to the, can you hear the sound? Let me know if you are not too well. I will just go through it.
It's an honor to be here in
skeletal maturity. And X-ray, in X-ray, the more 10-degree intervertebral extension in the sagittal plane and side tail on the frontal plane and rotation the vertebra in the axial plane. The basis concept, the prevalence is the 5.2%, more in female than men, and the cup angle, you can see more 40 gray. The prevalence today is at 10-1 for female. The curves prevalence thoracic in the 48%, thoracolumbar 40%, and double thoracic curve only in 3%. In the genetic multi-possible partner inheritance and monozygotic is 63%, 50 grade is 8.9%, and the 15 locus X chromosomes. About the natural history, the course is benign, but they are factors associated with the progress, more severe curve, female sex, skeletal immaturity, male gender higher in the atypical course, and lack of treatment with the bracing. Progression one grade per year of course 50 to 75 grade at skeletal maturity. Why to treat the clinical deformity, the psychological effect, and progression after skeletal maturity? The surgical consideration, heritage of child, the older age is associated a lower chance to progression, and the magnitude curve a gradient more the 40 degree, the chance needing surgery is high, and the growth potential growth history is very important, and the parent height and onset of menses, a person grow faster 1 year before onset menarche, and usually finishes growing 2 years after onset. And the research seen and the hand X-ray, the research seen is calcified the iliac apophysis and is a good sign of skeletal maturity. The skull being in 0 to 5, 0 is skeletal immaturity, and closed in 5, the skeletal maturity. In the hand X-ray, the presence of open the epiphysis, the proximal phalanx and the metacarpals and distal right. The patient most likely has more than 2 years growth remaining. Close the distal radius epiphysis indicate the skeletal maturity. The clinical evaluation, the neurological exam, the guide assessment, and the guide assessment, for example, ataxia, the guide assessment and sensory and motor evaluation is very notorious associated with high risk in the cases for syringomyelia or potential associated cherry malformation. In the skin exam, you have cutaneous abnormality and can be a presence of non-idiopathic type of scoliosis and should be kept in mind. And the other pathology is osteomastoid tumor located in the lamina G1 with the patient present a painful symptom. And the clinical evaluation, the coronal balance, sagittal balance, the oblique pelvic and shoulder balance, because the left thoracic curve, if possible, is not idiopathic scoliosis, and the most common curve is the right thoracic curve in idiopathic scoliosis. How do we classify? The first classification, the Dr. Mo modified with King in 83, classify in 5 type of curve in the coronal plane. The type 1, when it's a double curve, being the lumbar larger curve, and the type 3, the thoracic curve. For example, the type 3, the thoracic curve, and type 4, a neuromuscular curve in the form the letter C, and the type 5, the double curve thoracic curve. what the found in this classification is to indicate the level to arthrodesis and lower inter-observer agreement. And Lenke in the 2001 describes 6 types of curve: lumbar and sagittal modified, main curve, secondary curve, and structure curve. And the lumbar spine modifier designed the letter A, B, Z, and in the sagittal plane for hypo, normal, or hyper. In the type 1, for example, you have a main thoracic curve, unique, structured, and with the modifier when A, when E, B, and when C. And in 2 types, you have a double thoracic curve. Double thoracic curve, the main thoracic is the main curve, and the proximal thoracic is as small and structured. And the thoracolumbar curve is smaller and unstructured. In the type 3, a main duo, main thoracic is larger and structured, and the thoracolumbar is smaller and structured curve. In the type 4, the triple major curve, the main thoracic is bigger, and the 3 curves, that the proximal and thoracolumbar curve is structured. And the type 5 is a thoracolumbar or lumbar is a bigger and single structure, and the proximal and main thoracic is an unstructured. Type 6, the thoracolumbar or lumbar is a larger and structured, and the main thoracic is a smaller and structured. The difference is thoracolumbar lumbar. The difference is unified grade main thoracic curve. How we mentally organize with the classification, determination of type of curve. The spine, the length in step 1, the spine is divided to 3 regions: the proximal thoracic, the apex to T3, T4, or T5, and the main thoracic apex between the T6 and T11 and T12 discs, and the thoracolumbar lumbar apex between the T12 and L1, and lumbar apex between L1, L2, or discs, and L4. And the step 2 in the AP view cup angle. In the step 2, in the AP view cup angle, you are measuring the from cranial end vertebra or caudal end vertebra, and the end vertebra is defined as the vertebra that more tilted from the horizontal apical vertebra. The curve with the largest cup angle is major curve. And the step 3, using the left and right supine bending as well as the lateral radiograph, is determined whether the minor curves are structural or not structural. The residual coronal curve greater than or equal to 25 or supine bending radiograph are the criteria for a structural curve. In the step 4, with the center sacral sagittal line, you have the modified or lumbar modified. Modified I, the center line is between the pedicle and the apical level of the lumbar curve, and the B, the modifier B, the line touch the apical vertebra, and C doesn't touch any part of apical vertebra body or pedicle. And IIS goal of treatment prevent progression deformity during algodoc course, and correction of the clinical deformity, balanced harmonious spinal alignment, and level shoulder harmonious. In conservative management of the bracing, for example, is common practice but without evidence, low level of evidence in the reduction of progression. Curve progression later affect the quality of life, and low methodological quality. We have a lot of kin of the bracing in the world. In my country, have the Boston, the Providence, and the Wellington. We can use for the night is very usable. And the most accepted indication, the conservative managed embracing is the cup 25 at 30 degrees will progress more at 5 degrees, and curve in the 30 and 40 degrees. Immaturity, 1 year of the growth, research minor 3, and motivate parents and patient. And about the effect of the exercise on spine deformity is controversial. The systemic reviews have recommended the specific exercise based on evidence level 1B, and disclosed postural rehabilitation is more effective, and the exercise specific exercise is the most common or effective, more physiotherapy. How do selection the level? The upper level instrument vertebra. You can assessment the proximal curve, structure and non-structure, and carefully examine in the sagittal plane the kyphosis and account the shoulder tilt. For example, shoulder in the left side elevated, the upper level instrumental vertebra in T2 and T3, and if both are level in T3 and the rest side elevate the shoulder in the T4 and T5. And how the lower instrumented vertebra define the end vertebra, the neutral vertebra, and stable vertebra. The end vertebra is the most tilted vertebra caudal to apex to curve. The neutral vertebra is the most rostral, not rotated, the vertebra caudal to apex, and the stable vertebra is the most rostral caudal to apex that is bisecting the central sacral vertical line. This is an example. IIM, 13 years old female, aesthetic consultation without pain. You can see a little the shoulder a little shoulder elevated in the right side, and the Adam test, you have a right curve hand. And when you use mentally the length classification, the step 1, you have a triple course, the proximal course, the main thoracic curve, and thoracolumbar lumbar curve. In this, for example, the main curve is the major curve, 59 degree, and the step 2 is the bending. The bending have only structural curve, the main thoracic, and the proximal is not structural, and the thoracolumbar is not structural. And then and the step 3 is the modified lumbar, is the stable vertebra in L3. And then in this case, for example, is Lenki 1B and 1B and in the sagittal plane. Imagine intraoperative, and the post-surgical imagine have arthrodesis in T4 and L3. Good correction in the post-operative, and the comparative pre-operative and post-operative. And I have other case. She has a scoliosis diagnosis in 11 years with progressive increase with irregular bracing. The spinography. The step 1, you have a 3 curves, proximal curve, thoracolumbar, and lumbar curve. In this case, for example, you have the step 2, a bending, and have an vault curve and a structural curve. And the modified lumbar is the type C. And then is this classification is Lenke 3 C modified lumbar. The MRI preoperative, X-ray postoperative, you have arthrodesis in T2 to L4 in the stable vertebra. Surgical consideration in the patient with a several curve You have position and the scoliosis in the prone position and the Jackson table and midline incision where the lever to fuse meticulous exposed to the posterior element performed steep to the transverse process and the inferior articular facet each thoracic level are osteomized with narrow osteotomy and increase the flexibility to spine. Expose the superior facet allow the removal of the cartilage surface to the cortication. Always use monaxial pedicle screws and the apical vertebra and the combination, the periapical thoracic pedicle for the grip and apical vertebra the rotation technique using modern instrument set is the next evolution for the periapical vertebra manipulation. We also mark the correlative correction the thoracal and lumbar rib prominence and put the bone graft and close the skin. The X-ray post operative have arthrodesis T2 and L4. You have shoulder level and the sagittal and coronal plane is balanced. The comparative pre-op and post-operative is a good result. Conclusion: the progression according to age of presentation and magnitude of the curve and length classification had to guide the approach and level selection based off the curve configuration and sagittal alignment and compensatory curve flexibility. The posterior approach should be considered for appropriate AAS patient. Thank you very much for your attention.
Thank you so much. This was a lecture given by Professor Juan Jose Hora. You might have seen him today earlier when he logged in just to say hi and to tell that he was going to perform a surgery today. So I think if you have got any question regarding this lecture, kindly email it to me, to us, to our organization page, and we will forward it to the speaker and we will send you the answers. Now we are left with our final presentation that is being given by um, Professor Georges Mattis. He's the head of neurosurgery in the University of Cologne. He has got interest in neuromodulation. You might have seen his lectures, his so many cases and things that he shared in his papers on social media as well. So we really wanted to add a new thing to share with, that is the spinal cord modulation for scoliosis, and we are really pleased to have his lecture again. He was also busy at some of his meetings, and we are pleased to have him send his recorded lecture today. I'm now sharing his lecture again. If you have got any question, please email to us. I will share the address with you.
My name is Georgios Matis. I'm a neurosurgeon. I'm working in the University Hospital of Cologne here in Germany. The topic of my talk today is spinal cord stimulation for scoliosis. Here are my conflicts of interest, not really relevant for this talk. The agenda: I'm going to speak about neuromodulation, the current role of spinal cord stimulation in the interventional pain management, how spinal cord stimulation can help patients with scoliosis. I'm going to present some new waveforms, and I'm going to speak a little bit about the future of the therapy. What is neuromodulation? It is the alteration of the nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. There are many diseases which we can treat with neuromodulation, among others pain and spasticity. In everyday life, patients that are coming to us are exhibiting trigeminal neuropathy, back pain, neck pain, arm pain, leg pain, phantom and stump pain, polyneuropathies, diabetic polyneuropathy, or neuropathy after chemotherapy, plexus lesions, angina pectoris, peripheral vascular disease, postherpetic neuralgia, or complex regional pain syndrome. Spinal cord stimulation, together with the intrathecal opioid and non-opioid therapy, are therapies that are acting at the level of the second neuron. It's only a part of the interventional pain therapy. We all know that we should start always treating chronic pain with non-opioid analgesic, then using mild opioids, and then strong opioids. In the end of the ladder, we have the intrathecal therapy. But we have seen that if we start with other neuromodulation options, such as pulse radiofrequency or peripheral nerve field stimulation or spinal cord stimulation, before even trying with opioids, then the clinical results are much better. Spinal cord stimulation, it is not a new therapy. We have this therapy for more than 50 years. Everything started with this paper published in Neuroscience 1965, the gate control theory, the first clinical application 1967 in a patient with lung cancer. The patient was satisfied, but unfortunately he died some days after the surgery because of endocarditis. What are we stimulating? We are stimulating the dorsal columns, we are stimulating the dorsal halls. There are segmental effects at the level of the spinal cord, but we have also supraspinal mechanisms. The concept is to implant one or two leads in the epidural space, do a trial, and if the patient is satisfied, connect the leads to a neurostimulator. In the very beginning, we had receivers, such devices that were implanted under the skin, and each time the patient wanted to stimulate, should wear this antenna over the radiofrequency receiver. We started back then with leads with only one contact, and then moved to leads with 2, 4, 8, 16, 32 contacts. There are some guidelines. In each country there are different guidelines. Inclusion criteria: the pain should be really strong and not responding to drugs, physiotherapy, or any other therapy. Exclusion criteria: severe coagulopathies, mental disturbances, addiction problems, secondary gains, inability to use the spinal cord stimulation system, an advanced malignant tumor, or infections in the area of implantation. The majority of patients that are coming to us are patients with failed back surgery syndrome or persistent spinal pain syndrome, and we know that the failure rate of the lumbar spine surgery is somewhere between 10 and 46%, meaning that the patients are not really satisfied if we keep operating on them. What about patients with scoliosis? We have many patients with failed back surgery syndrome or persistent spinal pain syndrome with concomitant scoliosis. We should start with a percutaneous approach when we implant the spinal cord stimulation leads on the convex side of the spine and the level of the apex vertebra. Sometimes the access to the epidural space is a little bit tricky. Why? Because sometimes the normal vertebral landmarks are not there, and sometimes some patients have also a spinal stenosis. This is why it's really important, before implanting a surgical lead, to do a percutaneous trial. Sometimes it's possible to implant a lead, sometimes not. In this case, in this article, the colleagues were able to implant a lead. The patient had a comb angle of 64 degrees with osteopenia and lateral luistesis at L3L4. Actually, the patient achieved a pain relief of 50%, which is pretty good for me, but my colleagues were not satisfied. They removed the lead and they did not implant a neurostimulator. Some case reports in patients with scoliosis: 46-year-old male with a history of 6 spinal procedures starting at the age of 15. The colleagues implanted a lead, spinal cord stimulation lead. At 22-month follow-up, the patient reported a pain relief of 60%. Another case report: 60-year-old woman with a history of L2 decompressive laminectomy, a spinal fusion surgery of L1 to L3. 1 week after the implantation of the lead, 95% pain relief. At 5-month follow-up, the patient, according to the authors, had a significant pain relief and a significant improvement in the quality of life. During the trial, the colleagues have implanted a percutaneous lead and for the permanent system, a surgical lead. Another case report, 72-year-old female with a left lumbar scoliosis with apex at L2 and a compensatory right thoracic curve. At 2 weeks after implantation, the VAS score was 0, no pain, with increased physical activity. More importantly, the patient was able to discontinue opioids, hydrocodone, and also gabapentin. This is a pilot study with 18 patients that were not operated on, and the colleagues saw here that with spinal cord stimulation we can achieve a pain relief in low back pain of 30 to 40% after 6 months. And the authors here are stating that if we have overweight or older patients, we should also consider about this option, especially if the patients have many comorbidities. The tonic stimulation was the gold standard, a stimulation with a tingling sensation. But then we had a burst stimulation. Here we have packets of high frequency pulses, another type of stimulation, subperception without tingling, or we have a high frequency stimulation with 10 kilohertz. And today we have also the option of this frequency pairing to use tonic stimulation, then high frequency, then once again tonic, or burst and high frequency stimulation. And there is a publication with this type of stimulation, of high frequency stimulation, a 69-year-old man with L2, L3 posterior and L4 S1 interbody fusion with a 2.5-year follow-up of more than 50% pain relief, but the patient can also function really well. He does not need any more a walker in order to walk. Today we have also the possibility to offer our patients this combination therapy. Combination therapy means we can have multiple therapies, multiple waveforms for one pain area, but we can also have multiple therapies for multiple pain areas. Another type of stimulation for back pain, another type of stimulation for leg pain, or we can use all these therapies sequentially with the hope that no loss of efficacy, no habituation is coming over the next years. In 2018, we planted in my hospital the first neurostimulator that could provide this combination therapy, and 2 years later, for the very first time in Europe, we implanted the MRI compatible version of this system. Why is this combination therapy a good thing? Because using different waveforms we can target different neural targets, or we can activate or stimulate the dorsal columns, or we can stimulate or activate the dorsal horns, or both of them at the same time. And we know that the majority of patients report better clinical outcomes when we are using a combination of multiple waveforms. And there is also an article, a patient with 43 years old with congenital scoliosis, with pain in the sacroiliac joint region. You see all the instrumentation here. After 1 month with spinal cord stimulation therapy, he had a 60% pain relief, and the ODX was much better. Using the new system with tonic, subperception stimulation, burst, or 1.2 kilohertz or combination therapy, the results can be really good also in this difficult patient group of scoliosis patient. Something new in spinal cord stimulation is this closed loop technology. Here the lead can stimulate the spinal cord, but at the same time can measure the reaction of the spinal cord to the stimulation and adjust the stimulation. We also have a new algorithm, differential target multiplex, or DTM. Here we can stimulate at the same time the neurons but also the glial cells. And we know that the glial cells outnumber neurons in the spinal cord with a ratio of 12 to 1, so they must be important. And we also know that they are involved in many processes such as neuroinflammation, amplification, modulation, and distortion of afferent sensory signals. We have many waveforms. Is that important? Yes, it is important because different waveforms can activate different regions in our brain, implying that we do have different mechanisms of action. What does the future bring? Wireless spinal cord stimulation, especially in patients with comorbidities or in patients who don't really want a bulky neurostimulator. We could implant a lead. We don't have a neurostimulator here, but each time the patient wants to stimulate, should wear a transmitter and an antenna over the lead. The future brings more data. We already have many mobile apps that are collecting this data. The future brings more waveforms. The newest thing is fast-acting subperception therapy, a stimulation with 90 Hz, but subperception. It seems that this type of stimulation can partially be effective for mixed pain syndromes, for a combination of nociceptive and neuropathic pain, and this is what we also presented in many courses this year. You can see here our poster presented in Dublin in Ireland. But above all these things, the most important thing when we are treating patients with chronic pain or patients with scoliosis is the teamwork and the compassion for our patients. Extremely important is also the collaboration, and national collaboration and international collaboration among all physicians. Thank you very much for your attention. Once again, thanks for having me.
Again, thank you so much, everyone who has attended our webinar today. It was a matter of huge honor to have all the wonderful people who are famous for their all the eminent scholars, surgeons here today, and to share all these lectures. And I really want to thank all of the amazing speakers who joined us live and who sent us the recording videos. And I think that the attendees might have liked them all, and I'm really thankful to everyone in the attendees who attended our lectures today. And it's a matter of huge honor and pleasure to have this privilege of organizing all these webinars. As a young neurosurgeon from LMIC myself, I really feel the need to arrange such education activities. All of these are free of cost, and all of these are recorded as well, so that if you have missed it, you can try to just follow them on our YouTube channel. I have shared our Facebook page where we usually update all our future events, and I've also shared the link of our YouTube channel. I've also shared the link to our WhatsApp groups, so kindly join all of these to stay updated and to access all our previous recordings. And I also want to invite you to three of my other ventures that includes a course that I'm doing with the WFNS Education and Training Committee. We've got our module 4 on 16th of July, that's on meningiomas. Kindly register to that. All the registration information is available on our page as well as on our Facebook. And if you want to just join and just get registered, and you will have all those things available. And the second webinar is a course of module 2 that's on pediatric neurosurgery with the ISBN. We have the module 1 held yesterday, and it was a very successful one. Everyone liked it. We had a huge turnout. Again, it's available as a recording, although you will have to have about 75% of attendance to gain the final course certificate. Every module will be certified separately, but you get the course certificate. You might have to attend about 75% of all the modules. So the attendance is very important in that. The second module will be held on the third Friday of July. We have arranged it in a way that every module will be held on the third Friday of every month, and it will the last one will be on January. The third program is I've got with the double ANS joint section. I'm honored to be the executive board member for the double ANS CNS joint section for tumors, and we are organizing the glioblastoma day webinar on 18th of July, and there will be another our monthly tumor headlines usually must be interested, also the neurosurgeons right now must be interested in the tumor research, and we share all those recent researches and recent advances in our tumor headline. It's a very short program of up to 1 hour. It will be held on 24th of July. You can just find the final slate on our Facebook page, and I will be really thrilled and honored to have you all around in all of these programs. All the programs are certified, and WCN MSMR, which is founded by me, is under. It was actually founded by me under the supervision and direction of the WFNS Education and Training Committee. So it's a big honor for me to arrange all of these. I would like to hear from you what your suggestions, your comments, and if you want any topic to cover in one of our series, then I will be very pleased to invite the relevant teachers, the mentors, the legends of neurosurgery on that topic. And please feel free to leave any topic of your interest that you want us to arrange. And if you and we also you might have heard about our TraumaCon 22. It was a mini trauma conference that was virtual and obviously free of cost, where we invited experts from all over the world. And obviously, we prefer the young neurosurgeons and trainees. So we just keep on doing this as well. And also, there are very very exciting projects that are under pipeline. I think that once we will reveal it, you will all appreciate it so much. We are working so hard to make it possible to promote neurosurgical education in every part of the world. And again, these are free of sponsorship and totally free of cost for everyone. It's a huge honor, and am really grateful to all the teachers and all the associations who are supporting the cause of promoting neurosurgical education. So again, thank you so much, everyone. Kindly just to leave your comments or suggestions or any topic of your interest that you want us to present later and arrange a webinar again. Professor Hamid, you are still here. Thank you so much, sir, for staying. And thank you so much for the amazing lecture. I guess he's online. Anyways, again, thank you so much. I'm hoping to see you again next month for all our modules and for our glioblastoma day webinar. And please do let me know. And also want to announce that every attendee of today's webinar will receive a free PDF copy of our upcoming book on scoliosis. So it was a matter of huge honor and pleasure for me. I think that scoliosis is a topic that is a little bit that has been overlooked a little bit, and especially the neurosurgeons are mostly who even have interest in spinal surgery do not usually operate on scoliosis that frequently. So being a neurosurgeon myself, I do believe that it is a topic of serious interest, and we really need to have enough knowledge for it. If we have a patient, we should know, even if we refer it to some expert, at least we should have enough knowledge, because even if you have to refer a patient to someone else, then we should have enough knowledge to know what the thing is and what's the possible management plan. So I think especially those of you who want to adopt the specialty of spine surgery as a specialty should be stay updated and to take interest in these and all those. We have also arranged a few virtual workshops, and we have got plans to arrange more virtual workshops in the future. So just stay updated, and we will keep updating. And there are a few other exciting plans that are in pipeline. I'm not going to reveal those, but those will be really helpful for everyone, because we are in the same boat. I am also a young neurosurgeon. I'm from the alumni. So I have seen everything. I have struggled my way through myself. So I can totally understand it. And I really feel happy that when I see mentors who are interested in supporting us and encouraging us. So I think that it is really important for us to be together and to do it together. So I think that there are a few things that it's hard for me to actually, not to share those plans, but those plans are really we are really working on all of those, and it's going to be really exciting. And when I will reveal it, you will all appreciate it so much. So again, thank you so much, Maximiliano Taluis. Thank you so much, workshops and seminars. As your words mean a lot to me. It's a lot of encouragement, and I'm really thankful to all of you for all the turnout and all the encouragement that you show to me. Thank you so much, Maximiliano. Thank you so much. Um, I think Dr. Weil has written. Thank you so much, Dr. Weil. I think that we are the same, but we are all in this together. Thank you so much, Maneha. Thank you so much. Again, thanks a lot for your time and for sparing the moment, especially on weekends. I think that every neurosurgeons do not have any vacation or any weekend. Uh, Better too, so we're being better. Thank you so much, Dr. Maximino. This means a lot to me because if you feel that I think that my work is done. We are all in this together, and I think my work is done when you feel that it feels energy, feels enthusiasm, and when you participate. There are more things in pipeline. I just can't wait to share it all with you. Please follow our pages and our WhatsApp group. And again, thank you so much. I think that we will be able to see you all again next month. So bye for now. Thank you so much for attending. I think it's late for everyone around the world. So just have a wonderful weekend today and enjoy your day with your family and at your work and wherever you are. And it's a huge privilege to come together from all over the world and stay together. It's really a global village. Thank you so much, everyone. Bye.